Hello, young people. Last day, our 75 hours of internship. I hope all of you had a good time. I did. And today is the last very interesting day for you. Today, two brilliant experts, a very, very, very talented young academician, an expert based out of Bangalore, Dr. Sachin Baliga, is going to talk to you about neuromodulation. I think as psychologists also you need to be aware about what are the other newer techniques which are happening. So we thought you should be able to be exposed to that, and you can ask him all the hundreds of thousands of questions. We also have the one and only Dr. Vishal Chabra, one of the most well-known psychiatrists of our country, who's going to also talk about virtual simulation as a technique, and he's going to talk about more on the neurocognitive aspects. How the day will today be, we are going to first show you a demonstration on virtual simulation, and followed by a demonstration on neuromodulation. And then our two experts, Vishal Chabra and Sachin Baliga sir, both of them are going to take you through the science behind these techniques. And once that is done, then Roshni and Anuna shall be talking about all your assignments. And then by 6 p.m., we should all be done by that time. And so yeah, there are the two exceptionally well-known people here. Dr. Sachin Baliga, a brilliant academic. I go to him for most questions, but the point is I don't know answers to any question. So by the time you reach my where I am, I don't know anything. So and Vishal Chabra is probably one of the most well-known names in the field at present in psychiatry pan India. We all look up to him. He's exceptionally well known, speaker at national international forums. He's instrumental in shaping the academics in the field, especially in psychiatry. You must be also seeing a lot of him on social media. Again, a very, very popular figure. So I'm going to leave you in two of these brilliant minds, and we thought we'll end on a high as we end our 75, our internship. So leaving you, young people, in the best hands, not just good hands, of Dr. Vishal Chabra sir and Sachin Baliga. And I shall meet you in the year 2025 if all goes well. Otherwise, stay in touch, stay connected, unmute yourself.
Thank you.
Yes. Sorry, I think everyone exited at the same time. And from my and Anuna's side, also a very warm welcome
So the
to
real
our
star is
speakers.
here, Roshni.
Yes. No, we are starting now. So, everyone, welcome to our 15th last day of our internship. So, like Dr. Parekh said, we are going to now start first with a quick demonstration on both virtual simulation and then RTMS. And then we'll get to learn about both of these techniques from our speakers. And no, for all of you asking, there will not be an assignment today. All right. So we'll just have a discussion, and the assignment links are going to be shut anytime now. So on that note, let's start with a demonstration, and then we'll invite back our speakers.
Sure.
All right. So as you can see in the camera, that is Surbhi, my colleague. She's a counseling psychologist, and she is our in-house expert on actually practicing virtual simulation. So I will not get into the theory because that is what you'll understand. So this is just a glimpse for you all to see what virtual simulation looks like. So as you can see, what Surbhi is holding in her hand is the VR headset. Which she's going to wear, just to show, let you all know the program, the activities that she's going to demonstrate are by a company called Virtual Leap. And these are cognitive training activities that we do as games and exercises on a frequent, regular basis with patients from different diagnostic profiles. So currently we have profiles made for patients with depression, with ADHD, that's attention deficit hyperactivity disorder, with schizophrenia, and with some mild major cognitive impairments, and maybe some early onsets of dementia. So those are the four categories that the kind of patients that we're using VR based cognitive training with. So I am not going to take too much of time talking. Instead, let's try and show you what actually playing some of these VR games looks like. So yes, I'm going to try and focus it on the screen because you can't actually see what Surbhi is seeing in the headset, but we're going to try and show a 2D version of that stream over here for you all to see. So you might want to try and zoom into your screens. We'll try and keep it as focused as possible for you all to at least get a glimpse of what VR looks like.
Yeah. Can I start?
Yeah, so let me just put the stream on. Wait.
Okay. Should I start the game?
Yes. So as you can see, this is the stream that you are seeing on the screen, which is similar in a 3D form to what Surbhi is seeing. So as you can see, this is the first game that she is trying to play. And that's a tutorial that she starts. So as it says, this game is designed to target cognitive flexibility as a skill. So as you can see, as Surbhi is waving her wands or triggers in her hand, she has to aim and throw the correct shaped block into the correct portal. And as you can see, the difficulty level will keep increasing. Now you can see the shapes are changing, and the portals in which she has to aim them is also changing. So now you have red triangle and a blue square. And there the shapes change again. Right? So I hope the screen is visible enough for you all to get an idea of what this game looks like. So like I said, this is a game called React, which is offered by Virtual Leap, a company, where we are using this activity as cognitive training for individuals who want to improve their cognitive flexibility. So actively used in patients with ADHD, also can be used in individuals with depressive diagnosis as well. So as soon as she's able to finish this round, we'll try and also show you a glimpse of another game if possible. जल्दी एंड कर सकते हैं जल्दी एंड कर सकते हैं नेक्स्ट गेम Okay, now we'll try and show you another game. So as you can see, that's the entire options of games at the menu, where you can scroll as per skills, whether it's for memory, whether it's for attention span, whether it's for information processing speed, you have spatial orientation, motor skills. So let's see what Surbhi is going to play next.
Should I start the tutorial for this?
No, you can actually start with the game. So, this is a game called Whack-A-Mole. And this is a game that focuses on, again, building reaction time, again, also your attentional deficits. So now you can see she is whacking the moles on their heads as they pop up. So, how these games work in terms of cognitive training is that the difficulty level, as you can see, as she plays it, the difficulty level is increasing, and this level is tailored as per each patient, each individual, each time. So, it's on a separate ID that you're playing it, so it remembers your performance each time. And the point is similar to how we would be doing paper pencil cognitive training exercises. This is again a more immersive experience where it's actually involving a multi-sensory experience of you working on your cognitive skills. And again, like I said, it has to be practiced regularly for a period of at least 4 to 8 weeks, after which we actually have been finding that this has been demonstrated to be improving at least some cognitive skills in the patients. As you can see now, the difficulty level has gone up and Subi is having fun whacking a lot of moles. Be careful you don't hit me, Subi.
So it's fun.
She's reached level 11. She started at 3, guys. We'll try and show you one more quick game after this. Quick. I'm so enjoying it. Pizza. Now she's going to play a game called Pizza Builder. This is now for executive functioning, for sequential processing, divided attention, and planning skills is what gets trained in this game. So she makes a pizza base. And she pulls some ketchup, or I think tomato sauce as they're calling it. So here, as you can see, there are multiple ingredients. So it's a exercise that helps us focus on building divided attention, which ingredient has been ordered, which one has to be put in which order, in which sequence, to be able to make the correct pizza. So as you can see, Surbhi is completely immersed and she's trying to pick the pizza from behind the laptop because she can't see.
Like put this?
Yeah.
Hmm?
Yeah. We'll go shift to RTMS now. Okay guys, so that was, I'm going to shut this. That was sit here. Yes, so that was an example of a short demo, whatever you all were able to see on virtual simulation, which is we are using cognitive training games and exercises by a company called Virtual Leap. And this is something that is an immersive experience which is used, and usually it's each activity is for 6 minutes, 4 minutes, 8 minutes. So total cognitive training exercise is less than half an hour, which is including a battery of a couple of games that are selected for the individual to improve their cognitive skills depending on whatever is indicated as per the clinical condition. And in the few weeks that we started using this, we've already been able to demonstrate positive results in some of the cognitive skills, if not all. All right, so that was a quick demo to start with virtual simulation. Now, as soon as possible, we are going to shift to the next room and show you a quick demo on how RTMS works. And that is a type of neuromodulation that Dr. Baliga will be talking about after the demo. Yes, this is a new innovation where we're able to apply technology to help. And I think AI and technology are innovations that we are welcoming in all fields, including in psychology and psychiatry. Again, in terms of logistics, I think the assignment links are still open as soon as I get free from this. If you all are saying you all have having difficulty in completing it, please enjoy today's session. Don't stress so much about the assignments. I mean, if you all are still struggling, we'll try and keep it open till tonight. So don't worry so much about that. Like I said, this internship is not just about, yes, I know hours on the CV and completion of assignments is important and that certificate does have value, but always something that has more value is having fun and learning while you have fun, right? So since today it's another demo that's going to happen, I would say don't worry about the assignment as of now. The links are still open. We'll try and keep them open by tonight, even after today's session. So hope you all are able to at least take out the time to engage and ask questions to our experts who will be live only during the live session, and you can then listen to the recording and complete assignments later on. All right. And yes, there was no assignment for day 4 and for day 12. There will not be an assignment today. At the end, both me and Anuna ma'am will be here today to discuss all the assignments from day 1 till now, right at the end. So let's now stop worrying about assignments and let's try and make the most of the session today. All right, so give me a minute. I'm going to switch off the camera as we quickly go and shift to the next room to show you a quick demo on neuromodulation. Yes, so as you can see, guys, I am in the RTMS room. Give us a minute as we adjust the camera and start giving you a quick demo on how neuromodulation works. So just give us 1 minute.
We can start now.
Yeah. Okay. So that is our in-house expert on RTMS, Dr.
Hi.
Mantosh, who you met already. Yeah.
So this is the machine, RTMS machine. This machine generates basically a strong magnetic field. This is the probe from where the magnetic field is sent to the superficial layer of the brain, the cortex of the brain. So this is the chair where the patient sits. Let me adjust the camera. Okay. So this is the place where the patient sits. Okay. The patient has to sit comfortably. They can bring their phone. They can, play certain cognitive exercises and puzzles and mazes. And this probe is placed on the lateral surface of the brain, dorsolateral prefrontal cortex, left side and right side, depending upon the diagnosis that we have made. Before we start the process of RTMS, what is necessarily is done is that we check the motor threshold of the individual. What is motor threshold? Motor threshold is basically how much electricity this machine has to generate, which stimulates the motor cortex of the individual to generate a movement on the arm. So if I am going to check the motor threshold of the individual, this probe is placed on the motor cortex on the left side, and the right arm, after generating the stimulating the cortex, the right finger, the right arm fingers, they will move, and specifically the thumb and the index finger. Once they move, that determines the motor threshold. Based on the motor threshold, certain calculations are fed here, and then we start the procedure. I'll just run a protocol, not on anyone, just for you to listen how it sounds like. Okay. So whatever you hear now is the time when the magnetic waves are sent to the surface of the brain. Let's say if the patient was to be still sitting there, and this probe, I'll just... So this is the probe that we're looking at. It has a curve shape, you see. So the curve shape is placed on the lateral surface of the brain like this. Okay. I'm not going to use it on myself, but I'm starting. So if you can hear the noise, that was the time when the magnetic waves were sent. So these are the two coils, and these two coils send the impulse here. If I keep my finger here, it will start vibrating. Okay, so that is how it looks like. I can show you a dummy how it feels like if I were to keep it here, and there's a button here which can send one impulse. So my, with every noise you can see my arm moving on its own. This finger of mine is pressing a button. So this is the amount of magnetic waves which stimulates the nerves of my arm superficially, and that generates the motor movement. And that is what we use. The magnetic waves are used on the lateral surface of the brain, and that stimulates the parts of the brain which are responsible for um the control of mood. It is used primarily for drug-resistant depression, treatment-resistant depression, and treatment-resistant OCD. When the traditional psychotropic medications and therapy both combined together, they're not working, then we use RTMS as treatment option. It is used for other in other conditions also, like in certain addictions, nicotine addiction, in neurological conditions like tinnitus. It is also used in mild cognitive impairment. In psychiatric conditions, we also use in treatment-resistant auditory hallucinations. So the choice of placing of the probe differs in different conditions. Uh, like we keep it here on the dorsolateral prefrontal cortex for depression and OCD. We keep it in the temporoparietal junction for drug-resistant auditory hallucinations. Right? Any questions?
I think there are some questions. But like I said, this was just a demo to start off the session. And now Dr. Baliga will be running us through actually the theory behind neuromodulation and how it works. And then if you still have questions,
Oh, Dr.
I
Baliga
think,
is there, then
yes,
my job is done.
yes, so these are our experts. All right. So again, I'm going to switch off the camera for a minute as we shift back to the room. And I thank Dr. Matosh and Surbhi for giving us a quick demo on both of the innovations that we're going to talk about today. All right. So again, a 2-minute break till I shift back to the other room. All right, guys. So that was our quick 2 demos for today. And now we're going to start with the 2 sessions. I am going to invite Dr. Baliga to start with on neuromodulation. So, Dr. Baliga, are you here?
Yeah, Dr. Vishal will be doing it first
First?
on
All right.
virtual reality.
All right. Perfect. So we have both Dr. Chabra and Dr. Baliga here. So first we start with virtual simulation with our in-house expert, Dr. Chabra. Over to you, Dr. Chabra.
No, you are the expert, actually. Hello, everyone. Nice to see everyone. I mean, I can't see you, but I know there are a lot of students here from all over India. This is Dr. Vishal Chabra from Delhi. I'm very glad that Fortis does this high tech. It's really high tech. The program they're doing for all of you, the amount of exposure they're giving you is very, very valuable. I thought I'll go first before Baliga does, because Baliga is going to, Dr. Baliga is going to get into the details of neuromodulation. And Roshni already showed you the virtual simulation. I thought I would set a little bit of context here for people who have, I mean, all of you must be around the age of 20, 25. So all of you are brought up in the digital age and seeing computer from very early age. For me, from psychiatrist from another era, uh, I think I finished 25 years of doing psychiatry, learning and doing Okay. I hope my audio is clear. I saw there's a lag happening. What I want to talk about, not just about virtual reality and RTMS, but I just want to talk a little broader. I'm sorry, I'm going a little off, a little tangent, but I want to put a bigger context of artificial intelligence in psychiatry. Whether you look at virtual reality or RTMS, also AI is or will be playing a role here. How is AI helping us? I want to talk about that briefly. Uh, we all know the brain is really complex. Uh, a single human brain has 10 to power, I don't know, I forgot, 28 or 27 neural connections. There are more connections than the number of stars in the visible universe. So there is a visible universe and invisible universe. In the visible universe, the amount of stars astronomers can see, we have more connections in a single human brain. And how this human brain behaves, we still grappling, trying to understand. The amount of data scientists are generating all over the world, we did not have the computing power to understand how that works. And now, with advent of AI in last 3, 4, 5 years, as we are getting better computing power, you will see AI coming in and helping us, uh, unlocking that data, understanding the data, tabulating the data in a much better way. A good example of that is the vaccination during COVID times. The vaccine, which was formed, which got approved within a year or so, was actually designed on AI. AI was used to look at that the protein structures of the viruses and how they will interact with the human cells, and the vaccine was based according to that. Similarly, now new vaccines being manufactured with the 3D technology of these AI. They're looking at how a better molecule can be designed without wasting uh, billions of dollars in labs and coming not to good results. When I talk about these high tech things, a lot of people get scared. People think that AI is going to take away our jobs. What will happen to psychologists? What will happen to psychiatrists? Because what if AI takes over everything? But I think AI we should look at not as a threatening technology, but as something which we can use to harness our power. Like again, Roshni was showing this demonstrating this video game which you were seeing, virtual reality, is helping brain get trained better. Uh, it is working on various cognitive processes of the brain, and hence it has been found beneficial in depression and anxiety disorders, and they're also looking at schizophrenia. Similarly, RTMS, which Dr. Bali will be talking about, has also been found to have useful in many uh, various various disorders, psychiatric disorders and neurological disorders. This is what I briefly wanted to talk about and put a little context here before I hand it over to Balika. And I'm open for when required. I just wanted to put this technology is going to change. We look at human brain. Technology is going to change the way we do therapies also. That's and how we give our medicines also. Thank you. So Roshni, you can now take it back to Dr. Baliga for his presentation. Hello. Okay, I think I think till Roshni, maybe Roshni didn't think I'll finish so fast. Maybe then I'll add some more stuff to it if they want me to speak more. But so another, if you want to look at another um, aspect besides AI, and when you're using these virtual games, one thing we can look at is what do you do with the data? How do you store the data? Where will the data, how will this data be managed? Who will be looking at this data? Will this data stay private or will it be shared? All that stuff is now being governed by the guidelines called as GDPR guidelines and HIPAA regulations, which helps you monitor the virtual data which is being created every day. Uh, okay, I think the prescript this PPT has been loaded, but this is very important. So one the good thing about is that we can do a lot of work online now, but how do you manage the data? For that, now the work is happening in terms of finding regulations and how the data should be stored, where the data should be stored, who has the right to the data, and how can you preserve the safety and confidentiality of patients. So that's an also important aspect. Now, Sachin, over to you, and I'll come back when needed.
Yes. Hello, everyone. I'll be picking up from here, discussing about the concept of neuromodulation. I think Vishal sir very nicely touched on the topic of AI and inventions in general, because it's something that has caused a lot of boom in every field that exists at the moment, and there's a lot of discussion with respect to psychiatry and psychology, particularly because we have always considered this field as something that requires an essential aspect of human touch, in terms of evaluation, interviewing patients, getting information. But the idea is that how can AI make work easier in terms of diagnosis, in terms of planning treatment modalities? That is the entire idea of this discussion that we're having today. So I'll be discussing on the concept of neuromodulation. I'm sure all of you saw that demo that was given just some time back, which was on the concept of RTMS. But I think you might not have actually understood what RTMS is, or what it stands for. So that's why I thought today we'll discuss on the idea of what neuromodulation, or basically modulating the neurons, is all about. So from a very basic concept, neuromodulation is basically alteration of neuronal activity through the delivery of electric or electromagnetic stimulation, or it can be any kind of a chemical agent or light. So as to cause some kind of a change or alteration in the way the neurons are functioning. So this can be done in the central nervous system or the brain, or it can be done in the peripheral nervous system. That is your everything below the brain, in terms of your hands and feet and the nerves in that. So psychiatric neuromodulation, when we specifically talk of that, it is all about alteration of the neuronal system function using energy fields such as electricity or magnetism or both, with the goal to improve psychiatric symptoms. I mean, that's a very self-explanatory thing, that we have an individual who is having psychiatric problems, and we are using some kind of an energy such as electricity or magnetism to improve these conditions. So the fascinating thing about this field, it's something that me and Vishal sir had been discussing also recently, is that it consists of both the oldest as well as the newest kind of treatments that exist in psychiatry and the field of mental health. Because a lot of times neuromodulation, when a person says, the entire focus goes on these high-tech devices and all complicated things, very sophisticated sounding and looking, which even most of the psychiatrists themselves will not get an exposure of within their field while they doing their MD or DNB. But it also consists of certain very old techniques, old but gold, that kind of techniques that also exist. So when we talk of neuromodulation, a simple way to differentiate is that how does the treatment modality function? Is it by inducing seizures in a person, or is it without inducing seizures? Why seizures and so much focus on that? We will come to that subsequently. On the other hand, it is either electrical or it is magnetical. So you can see that based on this, we have a nice 2 by 2 kind of a table that is created. Something that induces seizures, one of the top things that comes to a person's mind, one of the oldest treatments that ever existed, and something that has one of the best results in any medical field is the electroconvulsive therapy or ECT, something that is very commonly and sometimes notoriously known as shock treatment. On the other hand, the same thing when induced, meaning when fits are induced in a person using electromagnetic currents to generate electricity, it is basically something called as a magnetic seizure therapy. Although that is not so much of a commonly and widely practiced thing, it is still a lot into research. When we talk of non seizure inducing, we are talking of basically using electric current or magnetic stimulation to the brain, but it is not of the intensity that is enough to cause seizures. But you have to remember, when I say seizure, it means seizure as a way of causing treatment or causing an improvement. So when I say seizure inducing, it is not a side effect of the treatment, or but rather a way in which the treatment itself acts. So that is the major difference. So that's why in something that is non-seizure inducing, you have transcranial electrical stimulation, deep brain stimulation, and vagal nerve stimulation. Some of you might have heard it, where even in neurology you have deep brain stimulation, where specific areas of the brain there are electrodes that are inserted inside the brain after doing a surgery. For example, say for Parkinson's disease or for epilepsy in a person that is not coming under control, and through specific areas of the brain when targeted in a particular fashion, you can have improvement in specific symptoms that are being worked over. On the other hand, from the magnetic aspect of treatment, something that doesn't induce seizures, it is RTMS, which you just saw, which is repetitive transcranial magnetic stimulation. So that is basically what RTMS is. It is repetitive, it is transcranial, meaning that I am going through the cranium, through the skull. Magnetic, because it is using magnetic, and stimulation, because I am doing stimulation. So I see a lot of questions that are asking about, can psychologists also do neuromodulation? We will come to that in the subsequent slides, and I think you will understand it when we reach to that slide itself. So I thought that I'll have a few slides, handful of slides that talk on the concept of ECT, because there is a lot of misconception and myths and false information that exists related to ECT, partly which is promoted by movies, books, social media, and a lot of it also deals with misinformation that gets crossed or passed on from one person to the other. So the important idea about ECT or electroconvulsive therapy is that it induces generalized seizures using electric current for treatment of psychiatric symptoms. So that's something that we just saw or talked of in the previous slide. But the idea is that why do we induce generalized seizures for treating psychiatric symptoms? So this came from the observation of something called as an alternative psychosis. So something that was observed decades and decades back in the 18th century and even early 19th century, 18th century and late 18th century, that a lot of individuals who experience psychotic symptoms, say schizophrenia, and side by side also had fits as a separate illness, it was seen in these individuals that when their fits were brought under control with treatment, their psychiatric problems worsened. Whereas it was seen that when their fits were not in control and they kept on getting fits, their hallucinations, their delusions, and all the psychotic symptoms that they experienced actually got better. So from there came the idea that where seizures, generalized seizures that were being induced in a person's brain, actually helping in improving psychiatric symptoms. So from there, the entire idea started that can we induce seizures in a person to improve his psychiatric symptoms? So there were different methods that were then tried to induce seizures. One of the earliest ones was using insulin, because insulin, as we all know, causes our sugar levels to go down. And our sugar levels, if they go very much down, if you go into very severe kind of an hypoglycemia, that will cause a person to get fits, because when the brain receives too less levels of sugar, the brain will experience seizures. So initially, this was one of the concepts that was tried, which was called as insulin coma therapy, where you induce hypoglycemic coma using insulin and a person gets fits. But obviously, that was not a very it's something that did show results, but it was not a very safe kind of a technique. Later on, there were a lot of chemicals that were also tried, like metrozole, where using chemicals that cause a person to experience seizures, chemicals that were given through a person's vein, an attempt was done to induce seizures in the person. Subsequently, after trying different modalities, there came observation by this bunch of guys called Sadleti and Benny, was a psychiatrist and his colleague, that when electric current was given to the brain of a very mild intensity, it induced seizures in animals. And it was seen that after the seizure, the animal tended to become very docile and quiet for some time. So through that, they started experimenting with giving electroshock to the person, to humans, to understand what would be the dose and what would be the strength with which something like this can be done. And eventually, the concept of electroshock therapy, or something that we now call as electroconvulsive therapy, came into existence. So, when we talk of electroconvulsive therapy, one of the most important things that comes to any person's mind is that this is primarily considered as a line of treatment when there is a rapid need for response that is required. Meaning that when you really can't wait for medications to show action, when the condition is extremely serious and life threatening, either for that person or for people around them, ECT is something that is considered as one of the first lines of treatment. So, for example, someone who is having a very acute manic episode or a psychotic episode and is extremely violent and aggressive, causing a lot of damage around people, there is a lot of threat of harm to people around. In such an agitation case, a person who is extremely depressed, severely depressed, and is actively suicidal, ECT forms one of the first lines of treatment, because it is seen that even by the end of 2 or 3 sessions, sometimes right after one session, the person's suicidal thoughts and suicidal ideations reduce or disappear significantly. The third thing that also comes to mind is something called as catatonia, which is a very acute kind of an altered state where a person becomes very much like a statue, mute, not talking, not moving, sits in one place for hours together, sometimes days together, and is kind of completely uh, apparently in loss of touch with the environment around him, in a very stuporous kind of a state. So catatonia is something that is seen in patients of schizophrenia. Catatonia is something that is seen in patients who are severely depressed. Catatonia can happen because of other neurological conditions as well. But basically, any kind of a catatonia where this kind of a situation is there, a person practically stops eating food because the person is not moving. So you can't really give medications in some way as well. So a lot of times when a person is in such a state, I have sometimes seen individuals who have been brought in a situation where they have not had food for 7 days, 8 days, 13 days, and they're not talking to anybody. They're just sitting in one place. They're passing motions in their clothes. And even after a single session of ECT, they suddenly start speaking, asking for food, as if they are, suddenly restarted, or their bodies resumed from the pause mode that they were in. So it can be that dramatic kind of an improvement. The other thing that also becomes very important is refractory cases of psychiatric conditions, meaning that when a psychiatric illness is not responding to medications, therapy, and is very severe and disturbing to the individuals, for example, treatment-resistant depression or schizophrenia, ECT becomes a very important line of treatment. And something that's also mentioned here is augmentation of pharmacotherapy, meaning that medications are also given. With medications, a person is partly improved, 40%, 50%. For example, depression, person has partly improved, but still lot of lack of interest is there, doesn't feel like doing anything, still feeling low, not suicidal anymore, but not improving completely with medications, doesn't get up from bed, doesn't go to work. In such a case, to push the level of improvement to as much as possible completion, ECT is also utilized in such a state. In fact, what is the one of the most dramatic things of electroconvulsive therapy is that almost 70 to 90% of patients experience rapid improvement in symptoms. And even for depression itself, there are up to 80% remission rates. So it is practically one of the best results giving treatments across branches of medicine, because no treatment that you see has such dramatic levels of improvement. Unfortunately, a lot of people have a lot of misconceptions, because of which people are scared of ECTs, people avoid ECTs, people do not seek that as a way of treatment. So that's why I thought that we'll have a couple of slides to discuss this. In fact, ECT is something that is even considered safe for pregnant women, adolescents, and even older people. In fact, older people tend to respond very much better and have better chances of recovery as compared to younger individuals with respect to ECT. So a lot of times we will see that elderly person, severe depression, and in such a state, they are already elderly, so they are very prone to side effect of medications. And because their depression is severe, they require high doses of medications. Or else they have diabetes, BP, heart problems, and in such a case, medications will complicate the picture because there will be cross reaction of different medications, side effect of medications. So in such a state, ECT is actually considered as one of the one important lines of treatment. Even in pregnancy, a very similar situation where a severely depressed woman who is suicidal or trying to harm the baby, medications will cross the placenta and cause side effects to the baby. Very severely depressed, very severely psychotic. ECTs are actually given during such a state because it's something that practically happens between two electrodes in the brain. You don't have any physical side effects. You don't have any side effects like medications cause. So that's why ECT is actually considered safer as compared to medications as well. So, a very important thing to remember is that ECT is not something where a person is, forced into the situation without his knowledge. Something like that is done. It's a very planned and detailed kind of a procedure where a discussion between the doctor and the family members and the patient is done. Sometimes there is a situation where a severely ill person will not be in a situation to decide what is right or wrong for him. What we talk of in terms of Mental Health Care Act as a involuntary kind of an admission, where with explanation to family members and discussion with them, ECT is recommended as a line of treatment. uh, a lot of times there is a portrayal of ECT as a kind of situation where the person is awake and very much aware when the session is given, and the person feels that electric current that is going through his brain. That is something that is not that doesn't exist anymore. What we do is something called as modified ECT, where a person is given anesthesia, a very short course of anesthesia, whose effect lasts for around 5 to 10 minutes, during which the person is unconscious. Once the person is unconscious, he is given a muscle relaxant, something that paralyzes the body. And after that is done, is only when the electric current is applied, so that when the person gets a seizure, it is a seizure in the person's brain, but you will not get that typical physical activity that happens with when a person gets fits, which can cause fracture or dislocation and a lot of muscle pain, injury. As you can see in the photo that is there on the right hand side, if we give a muscle relaxant, a paralyzing agent to a person's body, and he's paralyzed, how do we know the person is getting seizure, right? Because he will be unconscious. He'll practically look like he's sleeping. So that's why what is done is that the blood pressure cuff through with which we check our BP is tied to one of the limbs. As you can see here on the foot there, the leg rather, the BP cuff is tied. And what we do is that we check the person's BP and we go around the 60, 80 millimeters of mercury above the person's BP, so that the blood vessels of the person's legs get shut. So this is done before the muscle relaxant is given to the person, because of which what happens is that the person's entire body gets paralyzed except for the person's that isolated limb. So be it a hand, be it a foot. After that, when the electric current is given, only that limb gets a seizure that is visible. But side by side, you can also connect EEG at the time when a person's ECT is done, and you can also check the electrical activity related to the seizure in a person's brain. So even if a person gets completely paralyzed and you're not able to see the seizures, you can still see it in the EEG that is done simultaneously as the session continues. So you have a situation where a lot of times patients even come on an empty stomach from their house, reach the hospital in the morning, their assessment is done. It is seen that they don't have any kind of infection or fever or any kind of an issue. Then you have an entire team of nurses, anesthetists, psychiatrists in that room, where then the person is taken on the bed, anesthesia is given. Once in anesthesia, person becomes unconscious, he cannot breathe. So you will have oxygen that is being provided side by side by the anesthetist. After that, once we see that the person is completely unconscious, then we tie that BP apparatus. We raise the BP cuff pressure. Then the person's one limb is isolated. We call it isolated because there the blood is not passing. We quickly then give the muscle relaxant, and once we confirm that the person is paralyzed, we give the electric current, which lasts for practically half a second to 1 second. Immediately, the person gets a seizure. The seizures are over within 15 seconds, 20 seconds. After that is done, immediately the BP cuff pressure is released so that the blood starts going in that limb. Within the next 1 minute or so, the person starts breathing because the muscle relaxant practically works for a minute or so. In the coming 2 or 3 minutes, the anesthesia effect wears off and the person wakes up. He's shifted outside the room. We wait till the person is awake completely. Then once the person is awake completely, he can have breakfast and then he can go home. So it's something that is actually such a very much of a daycare procedure, like how you would go to the hospital to the morning, do some test, and then come back home. And obviously, the person cannot drive by himself and go back because the ECT has just happened. So it is always recommended that a family member come with the patient. So as you can see in the photo here, the left-hand side one is a very famous photo from the movie One Flew Over the Cuckoo's Nest, where it is shown that the character Jack Nicholson plays is a very problematic character who creates a lot of disturbance in that group discussion and session that is going on. So then he's taken to the ECT room and given ECT, and he's very much awake at that time, and he's given the shock treatment. It's not something that works like that. It is given with a very specific intent for very specific indications. What is seen in the right hand side is actually how the ECT happens, where you can see that the anesthetist is standing, the psychiatrist is there at the head side of the patient who has kept the electrodes at the person's head. You see the nurse there who has tied the BP cuff to the person's leg, and you see the BP apparatus vertical one that is standing there. So this is actually how the ECT progresses, and absolutely not unlike how it is shown in the photo on the left hand side. So a lot of people think that because one of the side effects of ECT sometimes is transient memory related issues, ECT is actually given to make people forget everything. That is not the way ECT works, and that is not the reason for which ECT is given. There are individuals who can experience memory related issues, particularly related to recent memory. So, for example, once I have got 2-3 sessions of ECT, it is possible that I might have a difficulty remembering what I had yesterday, which relative had come to meet me. But in practically all cases, it is seen that once the ECT sessions are stopped, in the coming couple of months, most of the cases, all that memory issue that had happened becomes normal again. So a lot of people think that ECT is being given so that the person forgets everything, including his illness. That is not something how it works. Temporary forgetfulness is a side effect which is most cases mild and reversible and limited to recent events. And it is also something that is generally connected to number of sessions. So that's why what is generally done is that there is gap given between sessions. So that typically ECTs will be done like 3 in a week on alternate days, or 2 in a week, Mondays and Wednesdays, something like that. So that when there is gap between sessions, the person's brain gets to recover. If someone gets admitted in a psychiatric hospital, then he should be given ECT without his or her knowledge. That's not how it works. It's not like your hide and seek where a person is sleeping and somebody suddenly comes up behind him and gives him a shock. It's always given when after a doctor discusses with the patient and the family members and they agree and understand. So the detailed discussion of why it is being considered, what are the side effects, what are the risks of doing it, what are the risks of not giving it, everything is discussed. ECT experience is painful and horrifying. We just saw now that that is absolutely not so, because the person is unconscious and paralyzed. So that's why not only does the person doesn't remember about that process, the person doesn't also experience any kind of a pain related to the electrical current because he is unconscious at that time. And yes, the dose of that electricity that is given is actually mild enough to light a tiny light bulb for a couple of seconds. So it is that small an electric current. It is not an electric current that goes through the entire body. So when the person is being given that electric current, if you hold that person's hands and feet, you don't end up getting a shock. It is not like how a defibrillator works, where a person gets a heart attack or his heart stops working. And you see on those videos that someone puts those leads on the chest and that person shouts clear and everyone puts their hands back. That is an electric current that courses through the entire body. But when you talk of ECT, it is an electric current that goes between the two electrodes only in the brain. So that's why it doesn't go through the body. ECT causes brain damage and may reduce intelligence or change the personality. That is absolutely not so. It is something that with a mild intensity of current causes a person to get seizures. So temporary memory issues can happen, but it doesn't affect a person's intelligence and personality or anything like that. And like I said, unlike what is shown in the movie, it is not given as a punishment. It is administered to treat a psychiatric condition, just like we saw the indications that were there. And when ECT is suggested, a lot of times people think that, oh my God, when a doctor is saying ECT, then it means it's the last stage of the illness. and the person is not going to get better if we don't give ECT, and the situation is hopeless. It is not so. It is suggested as a line of treatment. You always have other options, but it is being suggested because that seems to be the best option that will help a person come out of the situation. So you can imagine that person who was severely depressed and catatonic and had not had food from 13 days. You always had an option of putting a tube through his nose and feed medications through the tube. And over a period of months, over a period of weeks, the person's depression might have improved. But with a single session of ECT, the next day he started eating food and he started talking. So you can imagine that alternate options exist, but this is not it doesn't mean that ECT is not being given, then there is no other option that is left. So, memory loss is something that is something that people who experience fits have. It's something that can happen as a consequence of anesthesia also, no? Because sometimes a person who gets head injury. So it is something that is discussed as a side effect before the treatment procedure starts. So, and again, it's something that doesn't happen in everybody. So that's why whenever a person is receiving ECT, the person's memory will be checked on a daily basis before the session, after the session. And at the first instance of us recording that there are certain memory concerns that are there, we immediately decide with respect to keeping a gap in the sessions, or if the person has improved enough, we stop the session. Typically, a person gets something like 10 to 12 sessions. Depression might improve within 6 to 8 sessions. Psychosis, schizophrenia might require longer sessions. Generally, ECT will not be given as a line of treatment by itself, like I said, because any kind of neuromodulation that we're discussing today, its effects only last for a few months to a year. So generally, it will be given to cause a faster improvement or to supplement the medications that are going on, and not by itself. So apart from temporary memory loss that can happen, and when I say memory loss also, it's not about where you are born, who are your friends, who are your family members, where did you study, forgetting your own curriculum or your name, not things like that. Things like what did I have last night? Oh, that friend had come to meet me yesterday. That kind of things, which also in most cases when you stop the sessions, all those things come back. So this is basically about the concept of electroconvulsive therapy. So with this in background, let us now go into the idea of RTMS, or repetitive transcranial magnetic stimulation. So I think this is something that you all will be much more aware of as compared to me, actually, because the idea behind this treatment is pure physics. That is basically electromagnetic induction. So when we talk of an electromagnetic induction, what we are talking of is that when there is a rapidly changing magnetic field in a primary coil, it will cause an electric current to be generated in the secondary coil. That is the basic idea. So we talk of electromagnetic induction with the idea that when you have two coils and when you have a magnetic field in the one coil, it will not cause anything. But if the magnetic field is rapidly changing, or say something like it is being turned on and turned off, turned on and turned off, then you will have temporarily a field that is generated, which will create a secondary electric current in the secondary coil. I think you all are aware of this. The secondary coil and the electric current that is generated in it will be of the same intensity, but the opposite direction as compared to the one in the primary coil. In RTMS, what is basically done is the same. Instead of the primary coil, what we have is this photo, which we saw Mantosh holding, right? The coil that he had in his hand. It basically has two wound up copper coils. And instead of the secondary coil, we have the brain. Because as we all know, brain is practically a bundle of nerves that courses through a lot of electricity, right? That's practically how neuronal connectivity and a lot of interactions happen. So because it has a myelin sheath covering around the neurons, our brain is a very good conductor of electricity. So that is why if you have a magnetic coil which you bring in front of the brain, and there is a magnetic field that is rapidly changing in that coil, it will generate electricity in the secondary coil, which in this case is the brain. So what we are basically doing with RTMS is that pulsed electric current is passed to the coil, which generates a magnetic field, and this field generates eddy currents in the nearby conductor. So to understand that when we talk of repetitive transcranial magnetic stimulation, it is not magnetic current that is actually causing changes on the brain. It is the secondary electric current that is generated through the magnetic field which is causing the changes. So as you can see in the photo here, we have the coil that is placed on the person's head. The blue circular line is the field of the electric current that courses through the coils. Because of this, you will have the magnetic field, which is in the direction perpendicular, which is generated, which is shown in purple. And this magnetic field in turn will generate electric current in the brain, which is shown here in the lower side of the brain as well. So what you're basically talking of is generating eddy currents. So people who are good with physics will be very much aware of what we are talking here. Eddy currents that are generated in the brain, which will cause stimulation of the brain. But it doesn't end there. It is not just that you stimulate. It is seen that the coil is very specific in the form of the shape of the coil and the size of the coil. The area and the place where electric current is generated is extremely specific. So that's why, as compared to ECT, this becomes a very specialized and a specific kind of a treatment where particular brain areas can be targeted when you have specific problems that are being discussed. So yeah, a bit more pictorial on what we are discussing here. Magnetic field, there is a coil here and that is generating secondary electric field in the brain. You can see here that since the neurons in the brain are in a particular direction, there is a specific kind of depolarization that happens in the neurons secondary to the electric current that is generated. That is basically what is being shown in this photo. So it is not like of those vibration devices that you wear on your stomach and it generates some kind of an activity. This is something that doesn't work like that. In fact, to make it clearer for you, the RTMS device is someone had asked a question, that how many Rontgen. So since it is a device that generates magnetic field, it is basically talked of in terms of Tesla, like how a MRI machine is. And RTMS generally generates magnetic field in the levels of 2.5 or 3 Tesla, which is basically as strong as the MRI machine itself. It's only that these fields are generated for a very fraction of time so that it generates the electromagnetic field. Because if the machine is on all the time, if there is a flux, then only the current is created, right? That's what the physics is all about. If there is no magnetic flux, then there is no current. So that's why this is the level of potency and strength that the device has. So this diagram basically shows which area of the neurons in the brain it causes the depolarization, because of which the neurons start getting activated. So yes, so basically magnetic field, the beauty of magnetic field is that unlike the electric current which you give in the ECT, which has to pass through a person's skull, magnetic field goes through the skull without any interruption, because magnetic field, it doesn't matter what physical solid surface comes in between, right? But the problem with the electromagnetic field is that it loses its power the further you go from the center of the coil. So that is why RTMS is always something that is discussed in terms of targeting superficial structures, like Dr. Mantosh said. So 2 centimeters at the max from the center of the coil, you can stimulate to the brain. So you can imagine when you have the skull and all the layers of our dura, pia, and arachnoid matter, and after which comes your brain, you can imagine that the depth of penetration of the RTMS coil is very limited and very specific to the superficial structures of the brain. So based on the coil geometry, differences in focality and the depth of penetration, different coils exist. Like there are photos here which show circular coil, figure of 8 coil or F8 coil. The deep coil that is mentioned here is in the form of a helmet that a person wears on the head. This is something that is called as a deep RTMS that allows to stimulate up to 5 or 7 centimeters deeper in the person's brain. But you can imagine that the deeper you go, the wider the magnetic field will be. So that's why the more precise you want to be, the less deep that you can go. So to give a simple idea, there's a difference between TMS and RTMS. Mantosh showed how when he kept the coil on his hand and he pressed the button on the coil a single time, there was a twitch in his hand, right? So that is basically a single pulse TMS, where a single kind of a twitch, a single flux of electric current generating a magnetic field will stimulate the brain. So if you keep it on the part of the brain that is related to a person's motor cortex, then the opposite side related muscle will have a twitch. So that is what we use actually to identify what is the motor threshold of that person, meaning that at what strength of the device, if I keep it on the person's brain, I can see a twitch in the person's hand when I stimulate on the person's head. So once I find out the minimum strength with which I can see the twitch, I know that, okay, this is the dose that I have to stick to. Depending on that, then the treatment is planned. When we say repetitive transcranial magnetic stimulation, it means that instead of that single pulse that Dr. Mantosh showed, we have a session of 20 minutes, 30 minutes, 45 minutes where there is this electric field that is generated, causing stimulation of specific brain areas. And when you give this kind of a treatment regularly, every day for weeks together, then depending on the pattern in which the stimulation happens, the underlying brain area related activity can be increased or decreased. Fascinating, right? So, for example, suppose, like Dr. Mantosh said, the temporoparietal area is basically the area of the brain which has the primary auditory cortex. It is seen that patients who experience schizophrenia and are having persistent auditory hallucinations, that area of their brain spontaneously becomes active, even though they are not actually hearing something from outside. So that part of the brain is basically overactive. So it is seen that in individuals who have persistent auditory hallucinations with schizophrenia, if you give RTMS to that part in a pattern which suppresses the underlying brain activity, a lot of individuals experience complete recovery from auditory hallucinations, or the reduction in the volume of auditory hallucinations, or they are able to ignore the hallucinations better. So the power of the hallucinations reduces. So basically, what I'm trying to say is that depending on the pattern in which RTMS treatment is done, it can either stimulate or inhibit the underlying brain area. And based on a lot of research that happens, you have different areas of the brain that have been seen to be acting in different ways with respect to psychiatric illnesses. For example, it is seen that the left-sided dorsolateral prefrontal cortex, or DLPFC, is something that is working very less as compared to the right side in patients of depression. So what is done is that the treatment that excites the underlying DLPFC is given on the left hand side to individuals, and it is seen that a lot of individuals with depression who have not responded to medications, the depression improves when you give this RTMS related treatment. So that's why when we talk of RTMS related treatment, it is not something that happens with a single session. It is something that is given 5 days a week, 6 days a week, for a period of 2 weeks, 3 weeks, 4 weeks, 5 weeks, 6 weeks, something like that. So when we do it something like this on a very regular basis, there are long-term potentiation or basically synaptic plasticity like changes that have been seen to happen in the underlying brain. There is alteration in the blood flow. Like for example, it is seen that in depression there is alteration in blood flow in specific brain area. So it is seen that with regular RTMS sessions, that is something that becomes normalized. The other important part is that our brain is not like this area works for this activity, this area works for this activity. Every brain area has connections to a wide variety of other neurons, and it is now very well known that psychiatric problems are not about one brain area or even one chemical like serotonin and dopamine and uh, noradrenaline. It is about connections between different brain areas. It is about circuits related to specific brain activity. So what is seen that with changes in activity of one place, there is naturally, because of its connection to the other areas of the brain, you will have improvement with respect to the connections with other areas as well. So it is seen to changes, improve a lot of neurotransmitter related activity as well. So as we saw the video recently, these are the photos here. So basically, the white colored dabba that you see is the TMS device. TMS meaning transcranial magnetic stimulation. It is basically a bunch of capacitors in parallel which store a lot of energy. When the device is turned on, it sends electric current through that black colored thing that is the coil. That coil has wound up copper wires through which the electric current goes. And each time you hear that tick sound, for a fraction of a second, the electric current goes, creating a temporary magnetic field for a fraction of a second. When you give it again and again repeatedly, you will even see sound like tick, 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 which we had seen some time back when Mantosh was showing it to us. Now you will have some electric current that will be generated in the underlying brain activity. So you can see an individual here who is being treated for depression. and he's sleeping, he's lying down on that chair, it is not suggested that the person fall asleep, because if the person moves, you can understand specific areas of the brain have very specific sizes. So you don't want to end up stimulating some other area of the brain. So the person has to be quiet and wakeful and sit for the session. His dosing is first calculated by targeting the motor area of the brain and seeing what is the smallest dose at which his hand or single muscle twitches, and then based on that, the treatment is then given. So, as you can imagine, this requires a lot of knowledge with respect to neurology, with respect to neurobiology of different psychiatric conditions, which areas of the brain are located where, how to isolate them, the DLPFC is located where, which area is located where. That's why it is something that cannot be done by psychologists, but it's something that has to be done by a psychiatrist. So, just shown in the image here, how different brain areas are located with respect to different activities. So DLPFC, temporoparietal junction, and stuff like that. So I mean, yeah, that was a lot of power-packed and intense kind of a talk that we had in the previous slides. Now the very simple things. The three main things for which RTMS is approved and is utilized is for treatment of depression, OCD, and for smoking cessation. Like Mantosh discussed, treatment-resistant depression, treatment-resistant obsessive-compulsive disorder, and smoking cessation. So as you saw in the previous slide, unlike ECT, the person is not unconscious, the person is not paralyzed, the person practically comes, sits, gets the session, and walks home. So it's something that is very much, different as compared to the ECT device. Much milder, much safer. Yeah, so these are the three main indications. And apart from that, transient treatment-resistant auditory hallucinations in schizophrenia and other kind of illnesses. In neurology as well, it has been tried in Parkinson's disease or migraine as well. So, like I mentioned in the previous slides, the acute treatment generally is something like 5 or 6 days a week for RTMS, unlike ECT, which was like 2 days a week or 3 days a week. And typically lasts for 2 to 3 weeks, something like 20 to 30 sessions. And as sessions progress every few days, you can evaluate the person clinically and see how much he's improving, he's not improving, and on the basis of that, then decide how much to continue. But generally, a minimum of 20 session, minimum of 2 weeks is what is recommended for any illness. OCD in general, being a very difficult to treat kind of an illness, requires more number of sessions, up to 30. The sessions generally go on for those many days, and then the treatment is stopped. So it is relatively safer again as compared to antidepressants and ECT, because antidepressants, like we discussed, cause a lot of physical side effects as well. ECT will require anesthesia. It will require the person to be unconscious. And as we know, anesthesia is something means that a person is made, to go in a reversible kind of a coma. So that's why a lot of assessment, his heart-related situation, is it good? His lungs, are they good? A lot of things are evaluated. But as compared to that, RTMS doesn't require all of these things. So it can even be given to people who have all these other existing health-related problems. RTMS doesn't cause memory issues. RTMS doesn't cause all those concerns because we are stimulating the brain with rapidly changing magnetic field. But the scalp of our brain also has a lot of nerves, right, on our head, our face, which cause sensory and motor kind of activity. So that's why one common side effect related to the RTMS is that when I keep the probe here and I'm giving the treatment, stimulation of the nerves in my skull can cause local muscle twitching or a kind of a tapping sensation on my head when the treatment is going on. Sometimes the nerves also supply senses to our mouth, face, teeth. So because of that, some kind of mild kind of a pain can also happen in these areas. And because that machine generates a lot of sound when it is going on, it's a good idea for the person giving the treatment as well as person receiving the treatment to wear earplugs at that time. But otherwise, there are no memory problems with respect to RTMS. The person is practically awake during the session. There are even kind of sessions that are planned where side by side with RTMS going on, if the person engages in certain meaningful activity, for example, if the RTMS is being given for OCD, And at that time, if we are targeting his OCD symptoms by doing some kind of therapy between the RTMS, it is seen that the combination of it works even better. Now, one important thing is that because in RTMS we are generating electric current in the brain, there is a small chance that that same electric current can spread to the entire brain and cause seizures or fits. So the risk is less than 0.1%. Important thing is that because there is a risk of seizures, we generally, when a person is being selected for RTMS, we take a detailed history, look for history of seizures, see if the person is taking any drugs, stimulants like cocaine, amphetamine, which can make a person's brain very hyperactive, medications. If the person is in withdrawal of any kind of things, because say alcohol withdrawal can make a person's brain very hyper, we do a person's EEG as well, so that we can see and rule out that there are any kind of risks of fits in this individual. And even the treatment that is given is on the basis of finding out the dose in an individual person. So that is why, as long as you stick to the protocol, your treatment dosing is proper, and you do a lot of history taking in before, you practically never see incidences of seizures in a person. But this is a rare but serious side effect in terms of a person getting a fit right then and there when the session is going on. I have personally never seen a person experience it. And in some cases, you also have to remember that if the person is an underlying case of bipolar depression, then sometimes it can happen just like with antidepressants, that you are treating depression, but antidepressants, if given in bipolar disorder, can make a person go into mania. Similarly, RTMS, if given to a person who has bipolar depression, they can have a chance of going into hypomania. We are all talking about RTMS only since quite some time. So yeah, with that, we come to the end of this session. The idea was to give you a simple background of some newer advances and newer kind of treatments that are undergoing. And yeah, if any questions, we can definitely discuss it here.
Yeah. So thank you. I think you did a fantastic professorial job, Dr. Sachin. Very nicely put. I think you put in very detail about how ECT is given and then RTMS in detail. So I'm sure it would have been very, very educational and knowledgeable for all the kids watching this. Any questions anyone has? And we can take the questions. Do you know, till we get any questions from the feed, do you know when was the ECT discovered? Or are you going to ask questions on that, Sachin, later? I can't hear you.
Yeah, we have decided no assignments today.
No assignments, right? I thought you were giving some MCQs or some questions you were going to ask. Is that true? Or does it?
I think they later on decided that because today is the last day, that's why it will be more of a discussion.
Okay, fine. So I think we should realize that ECT treatment is very, very old. And if Sachin can tell us, it'll be very, very nice. Sachin, if you can tell the people.
So
when
ECT
was
is
ECT
actually
discovered?
So ECT is actually something that began the earliest, awareness of it was as early as in 1930s. So it is something that's a very old treatment, and over a period of decades, there is a lot of advances and new things that have come up. But the earliest awareness of fits being used as a kind of treatment for improving psychiatric conditions has been as early as in 1930s.
Right, and the inventors of it were in Italy, and they got a Nobel Prize for inventing this technology. So it's a very old technology. It's not something new, but it has been refined. It still stood the test of time. It's not the flavor of the season. It's not favorable in many places as because of very damaging effect by the media, by the film media actually. But it's been very effective as I think. Now, similarly, when was RTM discovered?
Yeah. So RTMS came much later in the 70s. And that treatment over a period of time in the 90s started. So primarily came into neurology, and slowly they started realizing it has a lot of usage in psychiatry as well.
All right. So it's also not something new. It's not, but in psychiatry, it came only like 10 years ago in US, right? When it got approval in depression. So both the technologies are not new. One is really old. I mean, in 2030, we'll be celebrating 100 years of ECT. You know, yeah. Okay. Any questions which has come, Roshni, in the chat?
Yeah, I can see someone
Okay.
asking that if a person has fear of shocks, how can we give them ECT? So, like I discussed, during the treatment of ECT, a person is unconscious and is not aware of the process that is going on. So, a lot of times
Yeah.
you'll even
Yeah.
see people who at the end of session say that, did I even get ECT? I don't even remember. Because they go into the room and they come out and they are in their bed and they wake up. So, it
It's
doesn't
like
matter. Yeah. Yeah, sir.
it's
Please.
like it's like you go for it's like you go for surgery when you go to
Yeah.
when you
Yeah.
go to OT. You're wheeled in. You know you're wheeled in. Once you're wheeled into the OT, they'll ask you to they'll ask you to check something. They'll give you some drug and you knock off, and you realize when you get up, you wake up, you are in a post recovery room after surgery. It's like that. Same. It's much shorter, as Sachin beautifully described. It's very short acting. We give very short acting anesthetist, sorry, anesthesia agent, and we give very short muscle relaxant for patient. And the current is also very. And I like the comparison with the defibrillator. Like defibrillator is so dangerous. We give so much higher voltage to the heart to kickstart it. Compared to that, this is nothing what we give to the brain, and
Yeah.
brain is so
Yeah.
sensitive. Still, it picks up. But again, the important thing to remember, and that's why I keep going back to AI, even after almost 95 years of being found as a good treatment for psychiatric uh, uh, psychiatric issues, we still don't know how ECT works, and so is so many of other medicines, and we don't know. We don't know how therapy works also actually, where exactly therapy works. So there's a lot of studies going on. Don't It's nothing to be disheartening. It's just that the brain is really really complex, and I think people who get into mental health don't realize how complex the brain is. That I keep thinking about it. Uh, this is the only organ. Brain is an organ, right? The only organ which is studying itself to understand how it works.
Yeah.
Do you understand, guys and girls? See, ECT. I mean, see, if for kidney, you use your knowledge to read kidney or to understand kidney, heart. How do you understand brain? By through brain itself. So this is very very fascinating itself. Brain is using the brain to study itself and others' brain and see how it works. You know, I think this is very very important. So it's really complex. This is one of the final frontiers, if not the last frontier of today's tech. If we can find out what exactly is happening in our brain, so brain is very complex. And our earlier theories were like how Sachin said very nicely. We thought dopamine deficiency causes this, dopamine excess causes this, dopamine excess is causing mania and schizophrenia. Serotonin deficiency causes depression, anxiety. But we're realizing it's much more complex. It's not so easy. Earlier, there were just psychological theories for depression and schizophrenia, bipolar. Then there were chemical theories for depression, but it's not that. It's a much complex uh, understand much more complex mechanisms going on. We don't understand them completely, and that's where AI comes in. Again, I'm saying this because the amount of data we have, it's not humanly possible for scientists to sit and do it uh, in one lifetime. The amount of data we have. So there are um, there are projects going on in the world. We're trying to mimic and build a human brain through AI, and they're trying to see how it is worked. The project was supposed to complete in 2023. It has not nowhere near completion. I think it's pushed back because again the complexity is much more. Any thoughts? Anything you want to add to this, Sachin?
Yeah, I think there are a couple of more questions that we could take.
Questions? Sure.
Someone has asked that what kind of training is required and who can give this therapies. So primarily ECT, RTMS, ECT particularly is something that psychiatry resident learns as a part of his post graduation in psychiatry. So be it he's doing MD, be it he's doing a diploma or a DNB, he learns
Right.
electroconvulsive therapy as a part of it. RTMS is something most of us never got to learn as a part of our MD. It's a much newer technique. So that's also something that these days is available to learn in different major institutes like NIMHANS. And along with that, a lot of hospitals are government hospitals, colleges are also getting RTMS as a part of their department. So that's why students are getting to learn it. But primarily, it is something that is learned by a psychiatrist as a part of his medical residence.
Any other question?
Someone has asked, would a dextrocardia person's brain also be upside down like the chest organ? So, see, basically, dextrocardia means that cardia means heart and dextro means right side. So, someone who,
बंद कर दे वीडियो जा फटाफट जा.
when we learn MBBS as a part of our medical field, we learn that our different organs of the body develop in particular ways. And the heart particularly starts as a very basic kind of a structure, which is very similar to the heart of primitive species like a bird or a rodent, and slowly it grows into an adult human form and becomes much more complex. So in dextrocardia, as the name suggests, his heart, instead of growing in the direction of left hand side, is exactly as a mirror image in the right direction. So as the name suggests, it is only related to the heart. There is another illness also called situs inversus, where a lot of major body organs are in the exact opposite mirror image. But a brain is something that develops in a completely different way. So there is no illness where brain will be upside down or in a mirror image kind of a situation.
And that's a very fascinating, imaginative question. Right, interesting. But let's see if that is. How will that work out? That's an interesting thing. Yeah. What are your
Can this
thoughts on virtual
treatment
reality? Yeah. Okay. Yeah.
I'm just seeing questions. How is
Yeah.
smoking
Please.
cessation treated with RTMS? Which parts of the brain are primarily involved? So, with respect to smoking cessation, the idea is that a person experiences a lot of craving and desire related to the cigarette or tobacco consumption. There are a lot of connections, or a better word for that would be a kind of learning that happens in the brain with conditioning that happens in the brain with respect to cigarette or tobacco consumption. Like for example, if I'm bored, I feel like smoking. If I'm tired, if I feel like smoking. If it is morning and I've just gotten up, I feel like smoking. So what RTMS is seen to do is that through its treatment, it is seen to reduce the intensity of these feelings and urges, and through that it has been seen to help with smoking cessation, meaning that a person finds it easier to stop smoking, or a person who has stopped smoking will experience lesser amount of craving or has a lesser desire to smoke as compared to someone who has not received it. So it is again through the similar area or in the frontal cortex of the brain that is stimulated for smoking cessation as well. Has anyone ever died or injured or suffered a major injury due to ECT or other treatment methods? Yeah. So you have to understand that ECT requires a person to get into anesthesia, just like for any other surgery. If I am getting admitted for an appendix surgery, or if I'm getting for a thyroid surgery, any kind of surgery will require anesthesia. So when a person is being given anesthesia, he's made unconscious. So that is why anesthesia related risk of that will be there in a person who is receiving ECT. So it is the same risk as is there for any kind of a procedure where anesthesia is given. Apart from that, ECT in the initial periods when it was given as a unmodified procedure where there was no paralyzing agent. There were cases where a person can get dislocation or fracture in his bones, but that is something through which a person could experience injury. But these days, because a person is paralyzed, even those kind of things don't happen anymore.
Yes. Yeah. ECT has become much safer with modified ECT, and the anesthesia, because it's short acting, also the risk is very less. And if you're very careful, you get pre-anesthetic evaluation done for the client before giving ECT. Then the risk even because it goes down even further. Yeah.
Someone has asked, can these treatment methods also be used to treat personality disorders? No. Like we discussed the indications, there are very
No.
specific indications where this work. Maybe a person with personality disorder who experiences a very severely depressive episode and is suicidal might require ECT for the depression, but by itself, personality disorder will not respond or improve or is indicated for ECT or RTMS. 11-year-old
Any other?
child, yeah, someone has asked, 11-year-old child complains of headache while studying after an accident. Can RTMS help in that also? I think something like this will require a very thorough assessment of why the headache is happening, RTMS will not generally be considered as a treatment for something like this. Post head injury, if there are any concerns of headache, or if there are any eye related concerns because of which studying causes headache, are there any sinus related concerns? Because frontal headache is typically a consequence of either refraction related problem or sardi khasi sinus related issue. So all those things will have to be looked into. Is there a pain related to the fracture or accident that had happened? So the management will go on the lines of all those things. Can other types of addictions be treated by RTMS? It's something that is in research as yet. They are seeing if it also helps with alcohol related addiction. But as of now, it is something that has shown results and is approved only for smoking cessation. If a person does not want to take drugs for depression, can we use TMS in that case? That's a very good question. Generally, like I said, RTMS is not given as an monotherapy, a single treatment for people, but sometimes as a person's choice, it is something that has been given. Like I said, any kind of a neuromodulation treatment will show its effects and benefits only for few weeks to few months, after which the effect wears off. So there have been cases where individuals have insisted that I don't want side effects, I only want to come for RTMS and I don't want to take it. In that case, RTMS has been given. A lot of times you will have individuals who get better, their depression is all fine, and then some months later they will come, they'll probably take a handful of sessions when they start showing symptoms again and then get better. So there's a lot of research that is still going on with respect to, is there any effect of booster doses or kind of maintenance sessions that can be given timely, intermittently, to prevent relapse of illnesses. So primarily all these treatment modalities are only given for serious, resistant and not getting better kind of illnesses. But sometimes as a first line, if a person's preference is there, something like that has been done.
Also, in a similar lines, maintenance ACT has been tried in the past successfully. Like you were saying about RTMS also. Maintenance ECTs in resistant OCD patients, in severely depressed patients, RDD patients, recurrent depressive disorder patients, it has been tried as a maintenance therapy in schizophrenia patients also. Same thing.
Yeah.
Same thing.
Someone has asked, does ECT require informed consent of the patient? Absolutely.
Yes.
It's something that requires informed consent of the patient in cases where the person has a severe mental illness. Yeah, sir, saying something.
or or the relative if the patient is
Yeah.
involuntarily admitted.
Yes, yes, yes.
Yeah,
In
patient
cases
is
where the
not in a
person is
condition
not
to
in a state.
understand the condition.
Yeah.
Yeah,
Yes, yes, yes. For example, a person who is
one or two.
extremely, severely psychotic and doesn't think he's ill, he's experiencing hallucinations, he's not willing for treatment, he doesn't think he has a problem. In such a case, family members, through an advance directive or because the person doesn't have a capacity, the family members become the next of kin who will give the consent for the treatment. And in such a case, as the person starts improving and develops a capacity to understand, then the discussion is done with the patient, say after 3 or 4 sessions, that this is the kind of treatment that has been going on, and it is with this that you have improved. And through that, then the person's consent can be sought. How is ECT induced seizure different from normal seizures? That's a very good question. A lot of times we would also joke that, if a person has epilepsy and has a psychiatric problem, why even give ECT? Just stop the person's seizure medications and let him get fixed. He'll get better. The problem is that when you get fixed as a part of normal seizures, it happens randomly. It can happen when you're driving a car. It can happen in the middle of you walking on the street. You can fall, you can get injury on your head, you can bite your tongue, you stop breathing, you can get a lot of complications as a consequence of that. And when a person is getting seizures, he stops breathing, so the person's brain is not getting oxygen for that while. As compared to that, when you give ECT, it is in a safe environment where everything is monitored: heart rate, BP, breathing, your oxygen levels. You are provided oxygen. It is given in a very specialized way. There are anesthetists, doctors, everyone is around. And there is a mouth gag that is inserted in the mouth so that when the person gets a fit, the person doesn't end up biting his tongue. So it's a very safe kind of an environment where, but yeah, the seizure that happens here is very much like the seizure that happens there. The only difference is that the environment is completely different.
Controlled seizures. You can say we are using
Yes.
controlled seizures. That is a benefit of it.
Yeah. And we can also see that if the seizures are going on for too long, if it has crossed 20, 30 seconds, we can even give an injection and stop it. So it is purely in the control of the
Yes.
team there. Yeah.
Yeah. True. Because it is not therapeutic to so just to add this, it's not therapeutic to give longer seizures. Let's say somebody is having seizure beyond 40, 50 seconds. It's in fact then counterproductive. So it's good that Sachin talked about it. So we need to stop. So again, our ideal is 20 to 30 second seizure, maximum 40. The moment it goes beyond 40, we give an injection to we stop the seizure immediately. And for the next ECT session, we give the lesser threshold of the current so that the seizure doesn't go for such a long time. So all that is under our control, and that's why ECT is much better than having a normal epilepsy which a person has.
Can RTMS be used in migraine patients who don't have much help with medications? Yes, that it is something that is used in migraine. Someone has asked, it is also used in tinnitus patients. So yeah, Juhi has again asked, does controlled seizure not have any medical consequences in the following years as compared to regular seizures? Actually, no. One thing is that when we say regular seizures, again, when we talk of regular seizures in terms of an epilepsy, with recurrent seizures, a person might not get oxygen at that much time. With recurrent seizures, a person can develop brain damage. But when we talk of ECT, it is a very specific session that happens for say 6 times, 10 times in a person's life, after which it is stopped. During the time of ECT as well, there is oxygen that is provided. There are doctors are available. So that is why some kind of damage that can happen to a person who has epilepsy and gets fixed all the time will not happen when a person is getting ECT. So no, there are no medical consequences. In fact, ECT has also sometimes been given in adolescents who have had serious psychiatric conditions, and it is seen that it doesn't affect anything from the long-term consequence in terms of how the brain develops and how the brain grows.
So this is very important. The reason that's why ECT has got such a bad press. Looks are deceptive, and all of your psychologists, budding psychologists, please remember that looks are deceptive. Sometimes things can look much more bad, how, but they are not. Taking a small tablet every day looks pretty simple, so it may not be. It may have its own consequences. It's slowly doing something to the body, uh, and ECT, as like Sachin has demonstrated in his talk, can be life saving, literally life saving. In you know, imagine somebody not eating for 4 days, 13 days, and start eating after a single shot of ECT. So ECT itself is uh, very helpful. But then again, because of that bad press and that stigma attached with it, it'll take a lot of time. Like how people never used to come to psychiatrist. The stigma attached with psychiatry. People won't go for therapy. A lot of you complain that people don't want to go to therapy, right? Therapist के लिए बस उसको आना नहीं चाहता. क्या बात ही तो करनी है इसमें क्या खास है? They don't. It's a specialized treatment. There are specific ways to do it. And again, therapy can be very good for someone. It's life. It can save life if the person understands what you're talking about. Or it can be. It can also if the bad advice given if the therapist is not well trained, or if sometimes people just do self learning and do therapy, it can be dangerous also. It's like that with any technology, with anything. We can look at pauses and so don't get too biased about ECTing being a very violent method or very disruptive method. It is actually a very helpful method, especially in today's environment where we give modified ECT under a lot of regulation, a lot of control environment. Similarly, for RTMS, we still are in the early phase of RTMS. Like RTMS therapy itself is very cumbersome. You have to the patient has to come 5 times a week for 4 to 5 weeks. It's very cumbersome. The person has to get out every day. So only people who live near the hospital where RTMS machine is, it's feasible for them. But I think over time, as research is happening, you will find like DPMS or other types of RTMS. There may be better techniques, better machines where you can just give like every alternate day or twice a week RTMS, and things may become better. So it's a evolutionary process. Again, for VR therapy, we have nobody there. So like virtual reality. Virtual reality, I remember when I was an SA 18 years ago or something, senior resident in GTB. Somebody came to me for VR therapy, the VR therapy we're doing. But that time there were no good headsets. It was what you call non-immersive therapy. The headsets were very, very remote, very primitive. And now, think because of the change in technology in 15, 20 years, because of immersive headsets, because of the immersive experiences, because of the quality of the games, uh, VR is coming out to be a much better form of therapy. Any questions?
Hello.
Hello, guy. Hello. How are you?
Hello, young people. Okay, I know we have what about 10 odd minutes left, and you'll be taking then all your assignments. So, just a couple of things. I think today's session was very intriguing. I was listening on the back end. Also, because some of these things, we've started RTMS, and I'll be very honest here. Um, I wasn't it wasn't there in my time, right? A lot of times when you don't stay upgraded and updated with science, you don't necessarily feel that what something will work or not. And very happy to have you know my fundamental belief that young people know better because they're closer to exam passing. My teacher always told me that the exam going student knows more than anybody else. So Sachin is our advisor to the RTMS neuromodulation program for the network of Fortis Healthcare and Adayu. I've also just shared the link with Adayu, and just to tell you, it's a unique initiative by Fortis Healthcare. We launched this vertical, and in March we started with our first. You met Saurav, that was United We Care. So that's our foray into AI and mental health. And I still remember the interesting conversation you had with him. 3 hours of question answers, quite something. I never needed more breaks, and because I hardly understand some of these technical things. And in a month's time, we'll be launching. You saw the virtual leaks, virtual simulation. Uh, Dr. Chabra has talked about it. I think our team showed it to you, and we are going to start it in for neurocognitive retraining in some clinical conditions. And this will happen across the network of Fortis Healthcare. It's a very, very interesting program, and we've tested it and we've had very good results. Same for RTMS. I'm quite pleasantly surprised and almost feel stupid for not doing this earlier. So it's good to see that. And in the first week of August, we'll also be talking, sharing details of our first inpatient long stay collaboration, which will be shared on 1st of August. Meanwhile, we'll continue with this. Every year we do these internships. Fortis Healthcare does not charge for internships, and we'll continue doing this. We've had over 430 schools, I'm told, who attended the physical internship, and over 10,000 students for the online for school children and the pro-social. And then I don't remember the last number here, but I think it's about 3,000 plus people who've attended this internship over a span of 15 days. Your certificates, ballpark, give us a month and a half. Don't send me a reminder till third week of August. If till third week of August you don't receive the certificates, then anuna.bordolu@fortishealthcare.com, or of course mentalhealth@fortishealthcare.com. And that's how we will look forward to some of these things that we'll keep doing, and we continue to plan to do more of these innovations and initiatives. We have an innovation cell at Fortis Healthcare, and the constant idea is to have. Recently, we've added Gamma Knife for the first time in Southeast Asia, a very unique procedure. Not again something I don't understand, but quite something. And so that cycle will go on. And this is the first internship that Adayu did alongside with the Fortis National Mental Health Program. So it's special in our heart for that, because Adayu is the first dedicated vertical by a private healthcare player in the field of mental health. And I hope it paves way for more and more people to, when more and more colleagues from private healthcare to give more attention and focus to the branch of mental health. I think that's important. And I just dropped in to say this, and I'm going to. I know we'll now continue taking some of these questions, and let me ask a few questions. Let's start with Vishal. Put a futuristic hat on, Vishal. Give me a 10-year. What do you see? What all do you think will happen in 10 years? AI, we are already seeing happening. I mean, we are using it. Virtual simulation, we are experimenting with. RTMS, like you just mentioned, DTMS. Tell me, what else do you think? I mean, Vishal Chabra had into the future. And if there are people who plan to invest into any of these products, it's probably Vishal Chabra's way of telling you what's the future.
Thanks, man. I think what I look at is AI advancing, the technology advancing so much that we can uh, upload a human brain. Upload a human brain in the sense like the technology may go so advanced that all my memories, all my emotions, all my thoughts can be collected on a machine and uploaded on a server. That can happen in 10 years. And if that can happen, then that brain, really going really futuristic, downloaded onto a humanoid robot. And you have a person, you have a robot with your personality. That can happen. That can really happen. For that to happen, we need a model of the brain where we understand exactly how brain works, uh, where do chemicals move, how do proteins are synthesized, which protein gets synthesized, which gene gets activated for what. All that needs to happen. See, already there was a Human Genome Project, and in 2005-6 it finished, and they thought we'll be able to solve all the mysteries. We could not. Then there was a proteomics thing going on. Now there is a program called AI called as AlphaFold. This is by Google again. They have found all the proteins made by mammals, not just humans, all proteins, how are they made on Earth. They've found that technology. This is by AI. They've done it and they released that data for the scientists to work on. The data is so humongous that scientists are not able to grapple it. But the data we have already, like we had data from human genome already. So I think this will happen in future. This is what I'm thinking. We will have also uh, therapy bots like personal pets, computer pets. I'm sorry, robotic pets. All that immersive technology. Like I can't smell you. I can't. That kind of technology is also going to come. I can smell, I can feel, speaking to Samir, I can feel much more. It's not just a computer device. So all that probably will happen in future, in 10 years' time.
Okay. Sachin, where do you see neuromodulation going from here? The future. I mean, you and I had a presentation from someone. We can't share the who's and what, but that was an interesting pitch.
Yeah. So I think one important aspect of neuromodulation that will happen some years down the line is probably something that is a very wearable device, which you can take where you want, which you can do it at home, where you don't really need the expertise of someone or a need to go to a place and sit and do it. But as you can understand, that comes with a lot of responsibilities as well. But yeah, that's something that I can see in terms of neuromodulation. The other very important thing is that when we treat neuromodulation now, we are seeing that, okay, this person has this, and then we are giving the treatment, and then we are seeing, okay, what is the change now? But we might reach a stage where we can actually real time see what is the neuronal activity that is happening in the person's brain, and simultaneously on the basis of the change in the activity alter the treatment that is going on as well. So I see that, oh, okay, this is how the brain is responding, then let us change it to this, then let us change it to this. Something that is being already studied now called as phase locked kind of a neuromodulation. So you can imagine now when we are doing treatment, it is a very much of a black box kind of a thing. Brain को आपने एक बॉक्स में डाल दिया है, बाहर से आप ट्रीटमेंट कर रहे हो, अंदर क्या हो रहा है कुछ पता नहीं. But once you get information from the brain side by side, simultaneously, you can actually know असर हो रहा है नहीं हो रहा है, and on the basis of that, आप कम ज़्यादा भी कर सकते हो. That is
So,
something that would be
so,
really fascinating.
so EG plus neuromodulation plus brain imaging plus precision and
Yeah.
shorter duration and lesser
Yes.
number, right?
Yeah.
Interesting. The one thing I've realized and I continue to realize is that if you don't keep updated, like how your softwares are on your phones, when you keep getting those updates and all these apps, you do that in science. Young people, don't allow yourself to read from anybody's notes. They are history, and probably a lot has changed since you last read them. Journals and recent, and probably that's why these kind of conversations are important, because you will still read books, and I hope you do, right? But you will also get to hear from clinicians, and they'll be able to do that. Yes, a couple of answers. We will be switching off the recordings by tomorrow uh, evening, probably 5 p.m. or so. All of these 15 days will not be live after that. So if you want to do any revisions or if you want to have a look at anything for the last 15 days, do that till tomorrow 5 p.m. We'll be taking this off. We don't have a server strength to keep this going on, right? Most people's drives and everything else is getting full here. I don't have much left on StreamYard if I keep keeping on to this on a lighter note. But no, we'll be taking it off tomorrow, 5 p.m. Give yourself a month for these certificates. We don't do physical internship for masters or graduate and master students. The short internship that we have is only for school students, which does not involve exposure to patients. We maintain that. It's more like a classroom setting, but the classroom is in the hospital, and that will be happening after um, let's say, lots of aspects are there. Also, I feel that um, confidentiality, privacy, um, these aspects need to be looked into. Sometimes what happens if, as a clinician, you end up telling someone that have somebody sitting, uh, they may feel the pressure to say that yes, it's fine sitting, but you and I both know that you and I both would not feel very comfortable with it. Yes, I think we'll ask Vishal Chabra that because he probably might well be an editor on a few of them. Vishal, there's a question that can you suggest some magazines and journals related to psychology, psychiatry, since you read all of them and, like I said, probably write and edit them and advise them. So you can even tell us which all medicine journals you are editing, and that's good enough
Oh
information for
my
us.
God, that's very bad. Okay, thank you for embarrassing me here. Uh, I think there is the editorial journal I'm part. I mean, part of is Delhi Psychiatric Journal, that is run by Delhi Psychiatric Society. It publishes 2 editions every year. That's DPS journal. IPS journal, Indian Psychiatric Society Journal, IPJ, is also very interesting, and you should look at it. There's also Journal of North Zone Psychiatry. These are the three I look at closely. There's also a journal where you can publish as Indian Journal of. There is for psychology. I think my with a new PhD, but there is uh, Indian Journal of Psychological Medicine, if I remember correctly. I used to read it in my PG days. We needed to do that. Uh, these are Indian journals I can think of off my head. Otherwise, mostly journals will be the psychopharmacology journals and all that, which may not be interested. Guys may not be interested. I used to read British Journal of Psychiatry a lot and American Journal of Psychiatry. American Journal of Psychiatry has become much more biologically oriented. British Journal of Psychiatry is still has publishes a lot of psychological therapies. Uh, and then there is addiction. There is a addiction journal for patients. I'm sorry for advances in addiction. These are the ones I can remember now. Baliga, can you help me out here?
No, I think you covered
Whatever
everything.
I remember, this is what I. Because and if you want to go for some, so for students, if they want to go for some landmark articles, so they usually come in Nature or Science. These are the big journals. There's some groundbreaking work. They always come in Nature or Science. So that's about it. But I think if people look at Indian Journal of Psychological Medicine, that's I think that's where psychology stuff is going on.
Okay.
And there's
So, yeah,
psychologs. Yeah, yeah.
yeah, I mean, those are more like. So, if you ask, my opinion is I'd much rather have you read journals over magazines, to be honest. Um,
Yeah,
it's like if you will ask me
that's the only
which,
thing which came to my mind.
yeah,
Yeah,
if
yeah,
you'll ask
last May.
which book to read, I might have a whole list of my favorites in biographies and travelogues and fiction and non-fiction. Well, but you do read the textbooks, as simple as that. First
Yes,
finish the
yes.
textbooks and then talk about the other things. First, read all possible journals that you can, and then let's talk about um, you know
Other
the
magazines. Yeah.
this stuff. Okay, let's do this. Let's wind this up, and we'll first thank both our experts. Sachin, always a pleasure. It's been a learning curve working with you for the past. What I don't even know how much time flies. How long have you been with us now?
Since last year, Feb.
Why does it feel like a couple of years? Am I aging so fast?
Yeah, yeah, yeah. More than that. Yeah. Because of his
But
involvement in the department, it's really nice. Very nice.
very,
Yeah.
very nice. Appreciate it. And we look forward to you guiding us, not just for neuromodulation, but all the other innovations. It's love
Absolutely.
to have a personalized search engine. I don't need to go to Google. I just need to give a call to Sachin and say, "Sir, इसका evidence नहीं है, इसका थोड़ा सा evidence है, इसका evidence नहीं है," and then story over. Right. But pleasure. Thank you, Vishal. You took time out. Always, I know how busy you are, and when I was introducing you, you're probably one of the best known um, people in the industry today, without a doubt. And I
I
don't even
second
know
that.
a platform. Yes, and I don't even know a platform
Thank you.
of our industry body which you are not closely involved with, and I think that helps shape a lot, especially shaping how the branch goes forward, working with young people, setting up clinical agendas, and setting up continuous education for colleagues. And
Hmm.
I think you're playing a remarkable role there. And you are far more busy than all of us
Thank you.
put together. So your taking time out here is huge. Um, I'll
Thank
just
you.
go out and water plants, and I know you'll be seeing patients. So, but that's also what happens when you are semi-retired, like I am, right? So, but it's been a pleasure, and thank you. And
Thank you.
we look forward to all your guidances. And as Adayu shapes up, and you see more and more presentations gradually having the Adayu's why, adding value to your IU, unmute yourself. And I'll now invite both Roshni and Anuna.Burdulu at fortishealthcare.com as we say goodbye. Thank you. Thank you. Thank you, Isha. Thank you, Sachin.
Thank you, everyone. Thank you.
Thank you,
Bye.
everyone.
Okay, let's add Anuna, and let's uh, Anuna.Bordoloi at fortishealthcare.com and Roshi Sonia here. I am going to leave, and we will meet someday all over again. And you will do your assignment bit that you've asked me almost every time I've come here. There you go. There are your assignments. Go enjoy, all of you. And I shall see you sometime soon, probably for the Bharat Panchal dialogues that will be coming towards the end of this year, where you'll get to hear from a lot of international experts, some conversations on and around uh, contemporary topics of psychology and their application. So wait for Bharat Panchal dialogues, and keep in touch. And yeah, so on behalf of Adayu, Fortis Network Company, from on behalf of the Fortis National Mental Health Program, and on behalf of Fortis Healthcare. Unmute yourself till we meet again. Thank you.
Thank you so much, sir. Okay, so here we are uh, discussing the assignments. Just give us some time. And if you have any question, we will discuss them. Now, okay. So somebody is asking how many assignments are there? Will there be any assignment? No, there will not be any assignment. Today, there was an assignment on day 1, day 2, day 3, day 4. We did not have any assignment. Day 5 we had, day 6 we had, day 7, day 8, day 9, 10, 11, 12 we did not have any. 13 we had assignment. And then 14 we had assignment, and 15th which is today, we do not have any assignments. And like I have said, few of you have mailed, so we have responded the same, that any day where we had an assignment, it is always there, either the assignment or the attendance link, it is there in the description box, right? So we do not have any assignment for today, but we had a beautiful discussion. We got to know about upcoming treatments. We got to know about RTMS, how beautifully it works. We got to know about very, very interesting VR, isn't it? So it's wonderful to know about all the upcoming these things. Oh, when certificates will be available. Certificates takes time because we have a lot of you. So it will take some time in sending all the certificates, but it will come to your registered email ID, right? So we don't need to worry about that. Can we mark the attendance for previous lectures? No, I think it was already, told on the first day itself, and we have repeated the same, that it will be closed in 24 hours, but we have tried extending it as much as possible. So The attendance links are still open for few. If you just want to go and quickly mark that, that is fine. But the assignments we are going to discuss. Yes, we are going to miss Sir's chai breaks from tomorrow, isn't it? But we should keep on having our chai breaks, right, with our individual works. The videos we do not have much bandwidth, and we have a lot of these things, so we will have to maybe take them out by tomorrow. So has already given you time till tomorrow, so till tomorrow all your videos are going to be live. You can still go and access it, right? Okay, then okay, let us see. What else? Okay, so I have just received a news that on your popular demand, we are going to extend the recordings till Friday evening 5 p.m. And Roshni ma'am is
Yes.
back with the news and
Yes, so
assignments.
I
Just to give
left
you
because
notes. Yes.
I heard everyone's responses. So I just had a conversation with Dr. Parik. We are trying our best to create more space. So yes, our recordings will be available till Friday 5 p.m. All right, that's one. Second, the assignments were supposed to have been shut by now, by 3 p.m., because we were now going to be starting the discussion. But again, since some of you are requesting, the maximum that we can do is we are going to be able to latest keep them open till 7 p.m. today. All right, that is the maximum. So no more extensions. And another thing that we can do is 80% of assignments and 80% of attendance is enough for you to get your certificate. Fine. So I think those are three logistic issues, all the repetitive comments now. I hope everyone is fine with this. All right. Any other doubts logistically before we start with the assignments? All right. So let's start with the assignments. So both Anuna ma'am and me are going to take turns and keep going into each day's assignments. So just to clarify again, day 4 and day 12 and day 15, 3 days, there are no assignments.
Okay,
Okay.
before you go on, Roshni, I think I'll just take one question. Somebody is asking, are there grades on certificates? No, we are not going to give you any grades. This is just for the purpose of learning. This is not your examination. So don't worry. Just enjoy the learning as much as you can take in, because it is from all the experts who are actually working on the field. And now let us go to the assignments. Okay, over to you,
Yeah.
Roshni.
Yeah, and we'll keep looking at your questions. Don't worry. All right. So I'm going to open the assignments on the side because I don't remember each question. All right. So going back to my day, the first session that we started with on day 1, which was on the introduction and the scope of psychology in the context of the national education policy and ethics. Okay. I'm quickly going to go through each question and just tell you all the correct answers. If you all are still not sure, go back. Now you still have access to the recordings. Listen in again. If required, go download the policy, try and read it, and you'll be able to clarify why that is the correct answer. So the first one, if as a professional training, if I can do clinical and non-clinical research, but I'm not adept at guiding students for dissertation, so the level of highest qualification would be an M clinical psychology, or the new terminology or nomenclature for masters in clinical psychology by the RCI. So that's for question 1. For question 2, which was if I've completed my undergraduation in bachelor's in applied psychology with for 3 years, what is the next option that I can pursue? I can do next is a 2-year bachelor's program with research. So that is the flexibility that the policy gives me. Question 3, which is according to this policy, again, which is the profession that they have come up with, which is serving as a first level contact, specifically in rural and urban community settings. That is option B, which is a counseling psychologist, which will have a license by RCI. So that is a new profession, a new qualification, which is getting a license, and a new course that they have planning to be launched from this academic year. That was question number 3. Then fourth is if in your specialized training you learned about mindfulness and interpersonal skills effectiveness and emotional regulation, out of the 4 options that are given, these techniques are most likely to fall into DBT, which is dialectical behavior therapy, as a specialized training. Then question 5, which is according to the National Education Policy, if I drop out or exit after 2 years of a 4-year course. So which of the following would be the degree that I would get if I complete 2 years out of 4? I would be most likely from this list to get an advanced diploma in that subject. Then question 6, which of the following is likely to be a breach of confidentiality? So if I'm having case discussions with my supervisor, that is not unethical. If I'm writing case notes with identifying details, again, just writing it with the identifying details in itself is actually not a breach of ethical confidentiality, as long as I don't share it or give it access. It could be in my own personal notes, and that's fine. And even providing clinical updates is also actually not at all a breach of ethical confidentiality, because that is required. So the correct answer would be C, which is posting an image including the patient on a social media platform where you're putting out the identifying features of the patient without their consent, without their permission. So that is where confidentiality is getting breached. Then question 7, which of the following situations would be, again, the question is which ethical principle? The principle of justice. So if you see, sometimes a lot of the options given here may be violating ethical principles, but specifically justice would be violated by option A, which is offering a range of professional fees on a sliding scale, because then you are in a way not being transparent and you're violating the ethical principle of justice for equally for all patients or clients. And your last 2 questions, if I am not adept in conducting assessments, specifically in neuropsychological functioning, and I'm not trained in providing neurorehabilitation, one which would be the next degree I would need to apply for as per RCI would be, again, the M clinical psychology, the Masters in Clinical Psychology by RCI. And second part of the same question, again, if which of these would be an ethical response for me if I don't know how to do neuropsychological assessment, and if I have a patient who's been referred for the same? The most ethical response out of all of these would be the last one, which is option D, which is that I would inform the patient, one, of my limitation in my expertise in doing such a neuropsychological assessment based on my training, and I could also help the patient in getting a referral facilitated for them to reach out to a professional with the required competence. So that becomes the answers for your day 1's assignment: 1D, 2C, 3B, 4D, 5A, 6C, 7A, 8 part 1B, and part 2D. Okay, so that was assignment for day 1. Over to you, Aruna. And yes, again, repeating answers to your questions: 7 p.m. today for all assignments. There is no assignment for today. And recordings will be available till Friday, 5 p.m. Certificates will be in a month and a half. Over to you, Anuna, for the next day.
Sure. Thank you so much. Okay, so I'll give you some time in going to the day 2 questions. Maybe if you have somewhere you want to check your answers. So, day 2, the first question was the child of a construction worker died recently. After that, the worker neither is going out nor eating food properly. The spouse of the worker has consulted the physician and stated that the worker has been doing this for about 2 months, which is the most likely diagnosis. So the correct answer is answer B, adjustment disorder. For prolonged grief, it doesn't meet the criteria, and the rest again, it doesn't meet the DSM criteria. So the best fitting answer would be adjustment disorder. Then we have a 65-year-old person, question number 2, working in a private sector, has been observed by the colleague to have features characterized by normal task taking longer than previously, increased efforts in doing multi-stage projects, and has difficulty in recalling events, relies increasingly on list making, like they need to remember, and has noticeable word finding difficulty. So the most likely diagnosis is mild neurodegenerative or neurocognitive disorder, uh, out of the rest 5. Right, we will need to consider here the age factor plus the cognitive symptoms that the person is showing. So it is more likely to be a neurological problem rather than a psychiatric issue. Like the options given are schizophrenia, depressive disorder, etc. Okay. An old patient was asked to the hospital with the history, was brought to the hospital with the history of auditory hallucinations. The patient states that some unknown people are conspiring against the patient, and he hears that they are talking about or commenting on the person's action continuously, which the correct option would be schizophrenia out of all the 4. Then there is another case of a 12-year-old adolescent who states that I cannot deal with this anymore, and the parent appears very exasperated, claiming that he has been getting into more and more trouble over the past 15 months since the finalizing of the particular long and difficult divorce between the parents, and the adolescent has been leaving the house at night without notifying the parents, and the parents do not know his whereabouts. The parents suspect that he is responsible in increased vandalism near the neighborhood, and he has recently been caught shoplifting in a nearby shop. So the parents are worried, and they come to there is a history of some comorbid diagnosis that we need to find. So the answer for this would be ADHD. Answer B, ADHD. That is the correct answer. Now, are you asking something?
I think y'all are trying to recall your answers that y'all submitted. Now, for you, it's one person trying to ask for a response. For us, it's thousands of you who've submitted your responses, right? So it's not possible for us to go back and share your responses. That's why we are trying to make you recall the
Self-check,
questions
right?
and tell you the wrong options also. So I think if you hear all of them, you will try and recall what you selected, and otherwise, if not, again, it doesn't matter. It's not about the marks. Learn and take away what the correct and wrong answer is, and I think that's all that's important. Continue,
Yes.
please.
Okay, yes. So the next case is of a 9-year-old child, and who was brought into this urgent care by both the parents. Over the past 18 months, they have noticed emerging habits, including repetitive squinting, grimacing, along with the associated clearing of throat or grunting noises. So there's noises like that, and these behaviors are occurring almost every day, frequently occurring together. The child has increasingly teased because of the peculiarities, and the child's anxiety has worsened. The symptoms, like with anxiety, the symptoms get worsened. The child has no major illnesses or not taking any medications, and the child's physical examination is within normal limits, with the exception of the above stereotypes. Further history would most likely to reveal which of the following comorbid diagnosis. So the correct answer is option C, obsessive compulsive disorder. Then going to the next question. A 48-year-old person with no prior psychiatric history suddenly was seen in the acute care with concerns of having a sexually transmitted disease. The person denies any dysuria, private part change, or lesions. The physical examination is unremarkable. When informed of this information, he insisted on being tested. And when inquiries were made on his sexual history, he claimed that being monogamous with the spouse, who happens to be a famous person. When confronted with the fact that the person's wife, let's call her Y, has been married 2 years ago in a secret ceremony, X adds they meet on weekends and have some, relationship, a physical relationship, but afraid that she has been unfaithful to him. Further history reveals that he holds a steady job and he lives alone in his apartment. He denies taking any alcohol, illicit drug. On MSc, he seems to be well dressed, well groomed, cooperative. Mood and affect are mostly anxious. His thoughts are illegal. He denies any suicidal or homicidal ideation, any perpetual disturbances. Which of the following is likely to be a diagnosis? Here, the Q itself is the famous personality, and he lives alone in the house, and he shares that they have been secretly married and with the MSc. So the correct answer is delusional disorder. Then a 28-year-old medical student who was referred to the OPD, to the Office of Student Affairs due to receiving an incomplete surgery clerkship. Upon questioning, he admits to sneaking out to the operating room in order to avoid participating in surgeries. When confronted his unprofessional behavior and expectations of the rotation, he claimed that significant anxiety involved around the operating room. He states that if not, it's not that I mind surgeries itself, but it's just the blood. The blood, makes me very, very anxious. So, what likely diagnosis it is to be? So, the answer is option D, specific phobia. So it is the phobia of blood. Now, question number 8. A 32-year-old female complains of ongoing headaches for the past 8 months. She has been having recurrent headaches, and she describes as she describes as bilateral, occipital, and tight squeezing pain around one side of her head and lasting for several hours. And she gets relieved with some anti-inflammatory medicines. Further questioning relieves that chronic feeling of fatigue, poor concentration, and she constantly worries about her job performance. And she is in a live-in relationship with her partner. She focuses on all these concerns and which interferes with her sleep. And there has been multiple occasions where she has panic, tremors, diarrheas, nauseous feelings, all of this, and she has gastrointestinal problems as well. Which of the following is the most likely diagnosis? The correct option is option A, generalized anxiety disorder. So that's the assignment discussion for day 2. Now we go to Day 3, over to you, Roshni.
Yes, so day 3, which was the session on clinical interviewing skills. So, again, your first question: which of the following is not typically included in a psychiatric history? So, your options was past medical history, which is very much included in a history, psychiatric history. Then, family history is also included. Physical examination findings is something that is not included in a psychiatric history. Educational background is also something that comes in an educational history and even in the socio-demographic details in a psychiatric history. So the correct answer is C, physical examination findings. Question 2, which was a scenario of a 45-year-old individual who's reporting persistent low mood, fatigue, and loss of interest for 4 months. The question is, which aspect of their history would be the most crucial to explore to figure out the contributing factors? So, their favorite television shows would not help us, giving us any insight about the contributing factors, nor would their preferred leisure activities, nor would it be their dietary preferences. The correct answer would be family history, if they have any of any mental health conditions, is something that could give us an insight to the contributing factors potentially to their mental health. So, correct answer is B. Then, question 3. Again, there was a scenario that you're conducting an MSc of a 35-year-old individual who's been brought in by their family. Appearance was unkempt and agitated. And once you begin the MSc, you notice that they are fidgety, they're avoiding eye contact, and they're occasionally muttering to themselves. So, based on the MSc, which would be the most relevant aspect to explore? So, you would not be getting an insight from mood or from orientation. So, the correct answer to understand next would be exploring their thought process to figure out, are there any formal thought disorders? Is there any other aspect of thought process in terms of content which needs to be explored further? Correct answer is thought process. Then, question 4. You are interviewing a 42-year-old who's this time been referred for an evaluation of anxiety symptoms. They describe episodes of sudden intense fear, palpitations, sweating, and sense of impending doom. And these episodes are lasting for a few minutes at a time and occurring unexpectedly, and the individual ends up also having an avoidant pattern as a safety behavior, where they would avoid the places where these episodes have occurred in the past. So the question is, which additional aspect of the patient's history would be the most important? So substance use or past medical history or even family psychiatric history would not be the next step to explore. The most helpful over here would be, because they're already reporting an actual episode of anxiety which is happening. So here it would be triggering situations or triggering context would be the next thing to explore in the context of these panic or anxiety episodes that the individual is experiencing. Then question 5, which is, which of the following is typically included in chief complaints of the psychiatric history? So it won't be the family psychiatric history, it won't be the demographic information, nor will it be past medical history. So the answer will be the patient's actual presenting problems which they present to the clinician. Correct answer is C. Then question 6, which of the following is not a key component of therapeutic alliance? So you cannot have a therapeutic alliance on without a goal. You can't have a therapeutic alliance without a bond, without a relationship being built, without actual tasks. What doesn't help build a therapeutic alliance is having a unilateral decision making, which means either only the patient or either only the therapist is taking a decision. That's not something that's collaborative, and that's not going to contribute to the therapeutic alliance. So, question 6, the answer is C, unilateral decision making. Then, question 7, a patient begins to treat their therapist like a critical parent during therapy sessions, expressing feelings of anger and frustration. This would be an example of not a rupture, not an alliance, not even counter-transference. This would be transference, which would be the correct answer. Question 8. Which of the following best describes a therapeutic rupture of an alliance? So, if the therapist is disclosing personal information, that is not necessarily a rupture. The therapist is accepting a gift, again, not necessarily a rupture. These are more ethical dilemmas, but they're not rupturing the alliance necessarily. Even a therapist expressing empathy and understanding, in fact, is quite crucial to a therapeutic alliance. So the correct answer would be if there's a disagreement about the treatment goals between the therapist and the patient, that is most likely to lead to a rupture in therapeutic alliance, which can be worked on and repaired also. Question 9. If it's a 37-year-old who's presenting with symptoms of depression, with sadness and loss of interest and sleep disturbances for 6 months, and in the initial assessment, if you consider the importance of family history, which would be the statements which would describe the role of family history? So it would not be that the family history is irrelevant, because that would be helpful. It was not that it's only important only if there's a history of substance use, and it won't be only considered if the individual expresses it. Regardless of all of these things, the family history is actually important because it can give us an insight into even the potential genetic predispositions. It can help us identify patterns of family history and mental illness presenting within the family history. Question 10. If you're a therapist working with a 20-year-old who's been experiencing severe anxiety, and initially the individual is hesitant to open up, and is somewhat distrustful of the therapeutic process and is avoiding eye contact, not giving too many responses. So again, which variable would be most likely to positively influence the therapeutic alliance? It would be consistently continuing as a therapist to demonstrate empathy and to try and understand the individual's experiences. Increasing just the frequency will not work. Just focusing on coping skills will not work. You going on and providing detailed explanations of your professional qualifications is something that won't necessarily be helpful in working on a therapeutic alliance with such a client. And last question, question 11, which is if you're working as a therapist with a 35-year-old who has a history of trauma, difficulty trusting others, and recently they've started expressing an emotional dependence on you as a therapist, reaching out to you between sessions and expecting you to immediately respond. So if you want to maintain professional boundaries while also supporting the therapeutic alliance with this person, you shouldn't ideally ignore the individual's attempts to reach out. You shouldn't also do the opposite of allowing them to contact you very, very freely and frequently. You shouldn't also reduce the frequency of sessions in response. The most helpful would be to you first clarify, set clearer expectations about your communication pattern, your availability as a therapist, and also discuss the importance of setting such boundaries in the therapy to not rupture the alliance and yet also be available and helpful for the patient. So that was assignment for day 3. Anuna, next.
Yes, so we go to the assessment assignment. Do you want to start with the MCQs and or I go with the maybe discussing the protocols first?
I think I can go with the MCQs first. So day 4 we didn't have an assignment, so we skipped to day 5. So I'll cover the MCQs and then Anuna will help you cover the protocols that were shared. So the first case, which was of an 8-year-old patient called P, who was referred for difficulties in sitting in the same place, self-smiling, social interaction. They were having difficulty in interacting with others. They would have difficulty in reading. The developmental history is given, and the behavioral observation showed that eye contact was not maintained, speech was not goal directed, and attention was not sustained. So the first question, which test would be useful to assess their social difficulties? It would be ESA, which is the Indian scale for assessment for autism. That would be the most useful scale out of the three. If you see the other scales, if it's a parent and teachers rating scale, that's for behavioral difficulties. House tree person is for emotional difficulties, and WISC, which is a Wechsler's intelligence scale, is for intelligence, as the name suggests. So if you want to assess social difficulties out of these four options, ESA would be the most appropriate test. Similarly, if you want to have the first choice to assess P's IQ, out of the options given, MISIC, which is Malin's intelligence scale for Indian children, would be the most likely approach. DP3 is a developmental profile, RAT is an achievement test, and CBCL again is a behavioral checklist. So if you want to assess IQ, out of these four options, MISIC would be the most likely answer. Then third, which test would suffice if we use it to assess P's comprehensive academic difficulties? So here it would be the NIMHANS battery for children to assess specific learning disorders. So VSMS would be a Winden social maturity scale that would not help us in academic difficulties. CPM is your colored progressive matrices, and GDT is your Jessel's drawing test, both of which are more helpful to arrive at an IQ and not for pure comprehensive academic difficulties. Now, the next case, which is of B, who's a 14-year-old in class 10 from Agra, and B has been facing difficulties in verbal communication. Non-verbal communication is still present, and there's a lot of fear before examinations, and they start to become aloof, and difficulty in sleeping and eating. Again, there were no significant complications in the developmental history, and in the behavioral observation, eye contact was very fleetingly maintained and affect was anxious. So in such a case, which test would be used to assess B's emotional difficulties out of the four options? Two options here can assess emotional difficulties. One is the CAT, the Children's A Perception Test, and second is HTP, which is House Tree Person Test. Now here a technicality, this is a 14-year-old, so because the cutoff is of 10 years, till 10 years only you could use the Children's A Perception Test. So here the most appropriate answer would be using the House Tree Person Test or HTP. Fifth question, which of the following tests would be a first choice to assess B's IQ? Again, here there are, if you see the options, there are only two out of the four options which actually assess intelligence. One is CPM, colored progressive matrices, and the second is BKT, which is a Binet-Kamath test. Again, here the technicality being the age. The cutoff for CPM is 11 years. This is a 14-year-old, so we would go with the BKT, which is the Binet-Kamath test. We come to the, okay, and I think these are Anuna's questions to answer. I'll skip to the next case, which is of J. This is the 32-year-old graphic designer who's had unstable relationships, who's had emotional difficulties, engaging in impulsive behavior, struggling with intense anger and difficulty controlling temper, feelings of helplessness, and some cognitive impairments also. So considering the history that J has of impulsivity and risk-taking, so the assessment which could provide insight into personality structure and psychopathology, again out of the four options would be MCMI, which is the Millen Clinical Multi-Axial Inventory. The rest of the others are cross-cutting is a screening measure, BDI is for depression, HAM-A is for anxiety. If you want to look at personality structure and psychopathology, it would be MCMI. And then if you want to understand the underlying themes in J's life and conflicts, again, the answer is also given as a clue in the question, which is a projective test. So out of these four options, there's only one which is a projective test, which is the thematic apperception test, which could help you understand underlying conflicts and dynamics and needs and drives which are based on which are underlying the individual's behavioral responses. Again, I'll leave the protocol questions for Anuna to answer. The primary focus of sentence completion tests is to uncover underlying emotions and thoughts, because it's a semi-projective test. In the case of R, who's a 40-year-old teacher who's been experiencing intense irrational fears, who's constantly checking doors and windows and is preoccupied with safety and has repetitive behaviors and intrusive thoughts. So for such an individual, if you want to get an insight into the relational aspects of R's functioning, again, out of the 4 tests, again, the thematic apperception test would be most helpful. And again, to directly assess the severity of R's obsessive compulsive symptoms, as again the name suggests, it's the obsessive compulsive scale by Yale Brown, which is Y-box, which would be the most helpful. Okay, I think the rest are the protocol-based questions that Anuna ma'am will help you answer.
Okay, so let us see. We go to the assignment given on day 5. So here, I think we have discussed a case with you. And the first one, the question number 6. So we have discussed a case with you and we ask you to do the scoring using ISA, right? So the correct answer for this is around, I mean, we can consider any calculation around 108 to 113, which is the maybe moderate level. So we will consider anything around that. So the correct answer is moderate autism. Then we had question number 7. It was a HTP question, right? Okay, so we have given you certain pictures to interpret based on whatever that you have learned. Now, again, HTP has a huge manual, so you cannot do all the interpretation, but this is again just for learning purpose. So we asked you to interpret the emotional and personality function of the person, depending on the whatever limited discussion that we had on the class, during the class. So for the house picture, the interpretation goes like this. The client has the need to structured environment, which is associated with the feeling of insecurities as indicated by irrelevant details apart from the house. The door indicates defensiveness. Then the picture of the tree. Absence of roots indicate repressed emotions. The no roots can mean insecurity again. Then in trees, in the tree picture only, the leaves indicate aggressive tendencies. Branches indicate limited skills to reach out. Trunk indicates employment of compensatory defenses to cloak and combat fear of personality diffusion. The picture of the person, it indicates the drawing size indicates acting out tendencies. Shoulders indicate the emotional dysregulation, and the mouth indicates immaturity. So that's HTP. Let us go to the next one. Oh yes, here comes the interesting one. So Rorschach. Rorschach, again, it is one of the most difficult tests to understand, right? I'm still learning. So it is not easy that, we just give you one class and you learn everything. But again, this was just for the purpose of learning. Let's see. So the first card we have given you, so we asked you for the location determinants and coding, right? So the first response was a bat, right? And the inquiry was given. I think all of that was given to you. So the location here would be W. I mean, the whole in the location sheet, when you see the whole thing was marked. So the location is W for the bat. The determinants would be FMA, and FMA means a flying animal, and C dash, right? So C dash again, let me go to the responses. So C dash again, it comes because in enquiry they have said that it is a black color bat, right? And we can see it is flying, right? Okay, so then goes a woman with her heads facing up. So a woman facing up, but we can see in inquiry, we can see the shape of her body. She is not moving, she is just looking up and standing. So there comes MP, movement P coding will come with the form, like how she has described in inquiry, the whole form. And in content, H will come. And I think we have mentioned her wearing a dress in the inquiry. The patient have mentioned wearing a dress in the inquiry. So the content of CG, clothes, also will come. Then on the third card, we have two elephants dancing. And in inquiry, we have said that gray color, shape of their trunk, body, legs are up, looks like they are dancing. So again, FMA, FMA, why? Because they are dancing with their legs up. And we have again the form feature. Then yeah, there are two elephants. The location is D1, and it is a popular response. So card 4 is heart, red in color. So the determinant would be because the color was mentioned first. So the determinant would be CF. The coding for determinant would be CF. And then they have, because it's a heart, it's an anatomical response to the content of AN will come. Then we have a butterfly. The fifth card response is a butterfly. Again, a popular response. Well, F will not be popular. Will it be? Yes. So the determinant is again F. And because here they have not said anything about, flying or anything. So it would be a simple F. F means based on the form feature, they have given the response. And then we have skull of a human, the light and dark contrast color and shape. So based on that, it is card 6. Let me see the location. So card 6, it's the skull of a human being, and the correct coding will be, where is it? The correct coding is F, again based on the form feature, and a human skull, so AN response. Then goes two people are sorry, so this one is a the skull is card number 3. Two people are holding utensils. So this is again card 3 response, because we have mentioned two people. So human response comes, and they are holding something. So in inquiry, when we ask what are they holding, then they have mentioned something, right? Yes, so something like utensil. So for that, HS will come. So the determinants will be F, M, A, and two people. So pair response will come, and then H and HS. HS is for the household items. Then we go to the next one. Card number 4, a snail. So for that, the correct response is going to be Yeah, so FT, why FT? Because I think they have given something as a textured response. So a snail, yes. So the texture is making it look like it is wet, right? So because that word is mentioned, so it will come as FT response, and uh, animal response will come along with that. But they have given as head of snail, so it will become AD. Then a giant, I think it's the same card. Yes, card number 4, a giant, black color, big feet. Then again, a giant. So color they have mentioned. So we will keep it as C dash and big foot. So FD response will come whenever we are mentioning big, small, and comparative responses. So FD comes, and then we have human H in bracket. So H in bracket because it's a giant. It is another version of a human being, right? So that's why H comes. Some imaginary figure or some monster. If all these responses come, then we give H in brackets. Then we have an animal. Okay, we have a bat as the fifth card response. That's again a popular response. So we have in determinants we have form response. Then in coding we have animal response, and it is a popular response. Then in card 6 we have a dragonfly and animal skin. Now animal skin again a popular response, but the dragonfly, the top part D3, it is form, and the content will be A. Then card 7, I think, yes. 7, we have one response, body of a girl wearing a flowy dress. And in inquiry, she said that half of the body and shape of breast and hips looks like it's a girl, right? So we have, because they have mentioned only about shape, it will come as form response. And because they have said half of the bodies and they have mentioned dress, so in content HD and CG will come. Then we have reflection of a cheetah, shape of it moving upwards. They said reflection of a cheetah, so the reflection, this thing will come with FMA, which is moving forward. So they have mentioned that the cheetah is moving forward, and the content will be A. Then comes the next response in the same card was rib cage, shape of it. Okay, again form as determinant, and in content it will be AN because of the rib cage. It is an anatomy response. Then we have two babies lying on their back. Pinkish color, looks chubby and small. So pinkish color, again, they have said the color has, looks like it has influenced on the response primarily. So it will be CF because they said it looks chubby. So they have considered the shape as well. And we have content as H, and there are two babies, so pair response will come. Then we have same card, card 9, a penis, the shape of it in card 9. So again, D5 is the area that they have given this response to. So the determinant will be F, and the content SX will come. Anything related to two human beings involved in any intercourse or any sexual activity, we will give SX, and if they name some sexual organs, then we will give it as SX response. Then we come to card 10. So we have three responses in card 10. We have two crabs, again a popular response. So their form and in content we will have animal response. Then they said it's lungs. So again, based on its shape they have given the response, so form, and lungs for content, anatomy will come. Then they said it is an artistic painting. It is so beautiful that so with so many colors, different shapes, the one you can hang in your house. So it is purely based on the colors, and they have explained it that it is beautiful. There are so many colors, you can keep it in the house. So abstract response will come, right? And the content will be art here. I think we have just one more. Yes, the DSM. We have given you a DSM scoring sheet, and we asked you a few questions based on that. So the answer for that will be. So the first question was, will mania be mania level 2? Do we have to conduct that? So answer for that is no, because in level 1 there was no indication for that. And the next question, what all we are going to measure, will be option C: depression, anger, somatic symptoms, sleep problems, personality functioning, and memory. So with that, we conclude day 5's responses. Then we will have to go to day 6 as well. So day 6 was mine. So maybe we'll just quickly go through it.
Yes, I think since someone has also said it is already 6 p.m. So we are
Yes.
trying to answer all the assignments. So maybe we'll go a little faster now because we do want to
Sure.
quickly cover all the assignment answers.
Yes. So a lot of you have said that the brain picture. A lot of you have answered, and I'm very happy to see that it is correct. So the brain picture, I have just simply asked you that you just indicate the lobes and the and the brain functionings briefly. I do not expect it to be like extremely correct, but just to see if we are understanding it properly. So that is there. Then the second question, which one of this is a part of case history? We have said behavioral observation, abstract reasoning, emotional functioning, or all of the above. But the correct answer is psychiatric illness history. The name history itself is there, so that's the correct answer, right? Then we have given you a case, and we have asked you to give a case study based on anybody that is there around you. I think that's again a very, very interesting way to learn case studies when you are going for your now maybe masters or other courses as well. You can do this for your practice, and most of you have given correct answers. Yes, then we have given you some BGT pictures. So and asked which of the uh, following questions will be the correct answer. Now I will tell you, because a lot of you, it seems like you had confusion between two options mainly. So I'll tell you why the correct option is. Why the correct option is C, which is rotation and closure. Because angulation is only till 45 to 80 degree. So more than that, this the whole figure is rotated almost 90 degree. So rotation is going to come. And closure, why? Because the whole circle is not completely closed. So that's the correct answer. Then in drawing two, I think most of you have given correct answers. It will be fragmentation. Then which was of the following is not an executive functioning, and the correct answer, where did it go? Yeah. So the correct answer is again long-term memory. Most of you have gotten it correct. Then which of these factors cannot cause brain lesions? Again, when we were discussing brain lesions, we have discussed all the factors. Only a broken leg cannot cause a brain lesion. So the option is that. Then we have given you a case study, and based on that, you had to do MMSC scoring. Again, very happy to see that you have given the correct answers. So here the MMSC score, anybody giving scoring between 10 to 18 is the correct answer, right? It will show moderate impairment, because the whole MMSC only, actually we have mentioned in the description on MSc only, I have given you all the answers. So maybe if you read it again, you will be able to see why moderate or 10 to 18 points is the correct answer. Okay, so with that, we are done with day 6. Now we will go quickly through the other maybe MCQs.
Yeah. So, day 7, which was your third wave therapies. The first one, how would you use dear man to address the case that was given? So the correct answer would be C, which is you'd say something like, I've noticed you often leave your belonging in the common areas and it's making the space cluttered. So describe, express, and I feel uncomfortable. Can you please put your things away? It would make the living space more pleasant for both of us. So describe, express, assert, reinforce. So dear man, and how you do it, of course, would be how you apply the DPT skill. Second, how would you use mindfulness to help in the situation that is given? Here you would option B, which would be to take a few minutes to practice deep breathing, to bring your attention to the present moment, focusing on one task at a time. Question 3, how will you use dialectical thinking? If you feel hurt that your friend didn't invite you, you would try and recognize that your feelings are valid. At the same time, you'll also consider that maybe your friend might have had some reason for not inviting you, and that doesn't actually diminish your friendship. Question 4, if you're experiencing negative thoughts about your own abilities, how would you use diffusion to manage these thoughts? You just notice the thoughts, let them pass, be mindful, and at the same time label them as just thoughts without getting attached, without attaching any evaluation to that thought. Question 5, which ACT based mindfulness skill could you use to get a broader perspective when you've been criticized? You could engage in using self as a context by trying to recognize that you're not just you are more than just a culmination of your thoughts, your feelings, and your mistakes. So that's a mindfulness based ACT skill that you could apply. Question 6, which of the following describes functional contextualism in ACT? It would be understanding psychological events in terms of their context and the function that they serve, similar to the previous question, how we applied it. Then question 7, why is experiential avoidance considered problematic? Because it can increase the intensity of that actually avoided experience over time, and therefore it could also limit your engagement in other meaningful activities as a consequence. Question 8, in this situation, how could you try and use wise mind in the situation of a job promotion? Here you would try and weigh the pros and cons of the promotion, consider both your career goals and your emotional well-being, and then try and use the wise mind to mitigate all those emotional challenges that you might encounter. Question 9, how would you use the how skill of DBT? In a heated argument, you could focus entirely on the argument, being mindful, staying present in the conversation, and fully listening to your friend. And the last question, what would be the first step of DBT in the given situation when the patient is frustrated and is not willing to change and is getting stuck at a point? You can help the patient to create a sense of willingness instead of willfulness. So willingness would be to try and accept the situation first and then recognize whatever is the common goal between the patient and the therapist. So that was day 7. Day 8 also, I'll quickly go through the CBT based MCQs. Sorry, no, that is something Anuna's doing, sorry. Yeah.
Yes. So before going to day 8, I have just seen that somebody has said that it's a flying bat. Yes, if it is flying or anything moving in Rorschach, it is mentioned, then it will always be FM. Right? If it is just mentioning the shape, then it will be F. Otherwise, if it is moving, then it will be FM. Then now we go to 28. Okay, question number 1, CBT framework that helps organizing and interpreting information in the world around us is called as schemas. So option C, schemas is the correct answer. A patient, question number 2, a patient that comes to who comes to therapy to with the chief complaints of low self-esteem, low self-confidence, poor self-esteem, and believe that they would fail in their upcoming exam. What is the focus of cognitive behavior therapy? What would be the focus of cognitive behavior therapy? So that would be changing the automatic negative thought that contributes, which is that, okay, they are going to fail in the upcoming exam, which can contribute and worsen their emotional difficulties, depression, and anxiety. So A is the correct answer. Then we have question number 3. CBT is based on the principle that physical problems are due to unhelpful ways of thinking, along with the learned patterns of unhelpful behavior. What is the process of problem solving in CBT? The correct answer is identifying the problem, then generate a list of potential solutions, evaluate the strength, weaknesses of each potential solution, choose a solution to implement, and implement the solution. Right? So option number A is the correct answer. Then we have question number 4. A patient believes that just because they froze once giving a speech, it is likely to happen again, and as a result avoids completely public speaking and errors in reasoning that lead to faulty assumption, that is called as cognitive errors. Okay. Then we have a patient who believes that hard work they put in towards their presentation at work was because of their good luck, correct star alignment, or other helpful colleagues, and not because of their hard work. So which one of the cognitive error that they are doing? The correct option is discounting the positive, which is option number C. Then we have, okay, next question number 6. Which of the following is true of both cognitive therapy and cognitive behavior therapy? So we had given you multiple options. They both are time limited, specific, educational approaches, a belief that problems are as a result of cognitive processes, changing our thoughts that can cause change our emotions or behaviors. So the option which is correct is all of the above answers are correct, because they all involve the cognitive aspect of it. Then we have patient DC comes with complaints of having developed fear of snakes after he was bitten. DC gets anxious now that even entering the reptile enclosure causes panic attacks. But as their current job involves working with snakes, what would be what their treatment would include? Relaxation to target lowering his anxiety. Yes, of course, that can help, or distracting techniques can help, but these are not long-term solutions. So the correct response will be option number B, creating a graded exposure hierarchy of the least to the most anxiety-provoking situation and helping him in developing better coping mechanisms. According to cognitive psychotherapy, cognitive phenomena which determine psychopathology, automatic thoughts, cognitive distortions, schemas, or basic instincts. So the correct answer is basic instincts. Socratic questioning, a tool for the therapeutic process, is employed in which of the following? Psychodynamic, logotherapy, behavior therapy, or cognitive psychotherapy? Of course, the answer is cognitive psychotherapy. Then P comes in. Okay, question number 10. P comes into therapy with complaints of anger outburst, where expression of their anger manifests in them punching the wall. What should be the focus of therapy? Out of all, the correct answer would be option number C. Once they are calm, help to identify the trigger that has led to the emotional outburst and help them to identify better coping strategies. So option C is the correct option. Then we have, okay, in a CBT session, the therapist and the client set specific measurable goals to address the client's depression. Which CBT principle do we, do this example imply? Now, the correct answer is option number C. goal-oriented approach. Question number 12. L believes they must be perfect every time they do something, leading to significant distress and anxiety. Their therapist helps them to recognize and modify these all or nothing thoughts. This process is known as option number B, cognitive restructuring. A client with depression is encouraged to schedule enjoyable activities and gradually re engage in hobbies they once enjoyed. This technique is called as cognitive restructuring. What happened? Okay. So, yes, we have four options: cognitive restructuring, relaxation training, behavior activation, systematic desensitization. So, the correct answer is option number C, behavior activation. Now we go to the case explanations with Roshni ma'am.
Yes, so again, there's no one correct answer because here it's based on your imagination and it's hypothetical cases that we're talking about. So I'll just try and give a sample example of what. So, for example, in the first one, where you're talking about a patient with suffering from depression, so what could be some common negative thoughts that such individuals experience? One would be, I always fail at everything that I try, which could be a cognitive error of overgeneralization. And reframing could be, relooking at there have been times when I've succeeded also. Not everything that I do ends in failure. I can learn from my past experiences. I can try again. Another negative thought could be nobody cares about me. So this would be a cognitive error of all or none thinking, which is thinking in extremes, black and white. Here, reframing could be that there are some people who do care about me, or even if it doesn't feel that way all the time, I do have friends and family who have shown some care. Another example could be that, if I've made one mistake at work, I'm such a stupid person, I'm such an incapable person. That could be labeling as a cognitive error. Reframing that and restructuring that could be something like, I'm not the only one, there are others, everyone makes mistakes, and making a mistake doesn't define my intelligence or my worth or my capabilities. I can learn from it and I can also do better the next time. Another negative thought could be that, my life is completely ruined. This would be the cognitive error of catastrophization. And I could reframe it and restructure it by saying to myself that, even though things could be not going my way right now, they're tough right now, there's still many aspects of my life that can improve. I can start taking smaller steps to rebuild and find newer opportunities. Right? So, like I said, not exhaustive, but just to give you a brief idea of the kind of negative thoughts and the cognitive errors and how cognitive restructuring can be used. The last question over here, which is about an individual X who's having a fear of making or taking phone calls, which is telephobia. So if we had to try and make a hierarchy, some of the the steps in that hierarchy could be just looking at the phone or thinking of the phone, to actually holding a phone, to maybe dialing a number, to making a short call, then making a longer call, then maybe an audio call, video call, and so on. You could make further steps into that. Other treatment options, if you have to make a treatment plan, of course, if you're using this hierarchy, this would be part of the technique of systematic desensitization, where we are starting with a hierarchy, after which you could practice relaxation techniques, and then using relaxation and this entire hierarchy, you start exposing the individual to that feared stimulus in a gradual, controlled manner. Other treatment options could be directly exposure therapy, where you just repeatedly have exposure to the feared stimulus of phone calls in a safe and controlled environment. Another option here could be behavioral experimentation, where you test the individual's beliefs and assumptions related to phone calls, making them challenge their negative expectations. If there was a fear, then you still attempted and forced yourself to, as an experiment, take that phone call. And after that, you go back and revisit what was your anticipated thought and fear and what was the actual consequence that happened. And that's when you again come back to cognitive restructuring techniques. You could also use some social skills training in such a case. So that is for day 8. Till Anuna ma'am comes back. Let me, in the meantime, skip day 9 for now and go to day 10, which was your arts based therapy. Again, I'm not going to be discussing obviously the experiential uh, activities that was for you. It was not mandatory, it's for you to experience and reflect on and learn from. But quickly, the MCQs. The first one: what does expressive arts based therapy involve? All of those above 4 options that were there. All right. Which was a rigid visual art medium. So clay, goop, acrylic paint, soft pastels are all non-rigid forms. The rigid one over here would be sketch pens and markers and pencils that require you to fill in specific, more rigid art forms. What goal focus do we start with in dance movement therapy? The answer would be just building a movement range and building kinesthetic empathy, which is option C. Fourth, which of if you're looking at making a playlist and just listening to the songs and just talking about how you felt while listening to that music, is the passive function of music, because you're not actively engaging with that music. So that example is just a passive function of music. Then what makes stories a therapeutic medium is, again, all of those options given above. Those are all the ways in which stories and narratives can work as a therapeutic medium. Then is question 6, which is as a part of building relaxation skills using creative media. If the person was listening to their breathing pace according and synchronizing that to the beat created by the therapist, this could again be meeting the goal of both managing the symptoms and also helping in the overall treatment as an adjunctive role. Then, for the last 2 questions of patient X, question 7, where X is a 9-year-old, and the patient, X and the therapist are together taking turns to draw on a piece of paper. So this would be a collaborative facilitation where it's not just the patient, it's not just the therapist, it's both together trying to facilitate creative expression. And the last question here, where a patient X here made a sculpture and then talked about their experience. So this part of verbalizing their experience would be an example of verbalization of the creative process. Okay, so I think Anuna ma'am is back. So I've covered day 8 and day 10. Now she'll go through the remaining, again, the missed out day 9 and then 11, and then we'll continue.
Sure. Okay. So let's go through day 9, the first few questions. So day 9, let's discuss the community mental health part first. So X is a pilot working in the aviation industry for 5 years. X has been an efficient pilot, very popular among people in the industry. However, X has contemplating about leaving the job as a pilot and starting a business. When X conveyed these thoughts to family, they were shocked. They were not able to understand why X would leave such a flourishing career and want to start all over again, and which requires too much effort and investment. X is not able to tell anyone about how mental health has been deteriorated by working as a pilot, whether whenever he has to fly, the day before is like a nightmare. He puts up with a smile and confidence and a face while at work, and little does anybody knows what he's going through. So here now we have asked you a few questions. Which of the following factors within the aviation community could have been most prevalent in contributing to excess condition? Absence from fixed working hours, uncertainty of life, or constant mobility? The correct answer is all of the above options are the correct answer. So, what is stopping X from disclosing the mental health problem? The options are loss of popularity, fear from becoming a topic of gossip, or fear of not being able to fly. Not being allowed to fly. So the correct answer is that option number C, fear of not being allowed to fly. Then the third, based on the same study, which of the following is initiative by Government of India to enhance accessibility of mental health services? The correct answer is option A, National Telemental Health Program. Which of the following is not an example of providing psychological first aid? The correct answer is option B, carefully listening to the person and listing out few strategies to deal with the situation. So this is not a psychological first aid, because as we have discussed, to be an expert or to be able to provide psychological first aid, we do not have to be experts. Then question number 5, the role of a mental health care provider in preventing suicide would be being sensitized to identifying warning signs. Then we go to the other part of the assignment, where we have we have given you a scenario, and after a thorough discussion, this person who has been underperforming, they said, they found that they are overwhelmed with their current project. The question, as a manager, this assignment was on workplace mental health. So the question is, as a manager, what would be the most effective long-term strategy to support Jay while ensuring project completion? The correct option is answer B, develop a step plan with Jay to manage their workload and check it regularly. Then scenario is Arjun has noticed his colleagues Minal has unusually been quiet, withdrawn from the past for the past few weeks, and she has also been missing deadlines. So the question is, how can Arjun help Minal? The correct answer is encouraging her to take some time off and offer to help her with her workload. Then another scenario where a company has decided to implement mental health program to support its employees, and the HR team has been asked to choosing the best approach. What would be the best approach? The correct answer is providing access to confidentiality to the counseling services so that people come up and take benefit of this program. Then a team has been working under high pressure for months and leading to noticeable signs of burnouts among the members. So what is the best approach to address this issue without sacrificing the project deadline? The best approach would be to provide additional resources such as temporary staff or to help in reducing the workload. Then another scenario, a team leader who wants a supportive work environment, what action should she take in prioritizing to effectively promote mental health among her team members? Out of all the options, option C, providing training on mental health awareness and resources available, is the correct answer. So with that, we are done with day 9. So Roshni, do we go to day 10?
Day 10 I'd already done.
Yes, day 10 is done. So we go to day 11, right?
Yeah.
Let's go. Okay. So day 11, health psychology. The first question, which of the following is which of the following best defines health psychology? The correct answer is option B, investigating how psychological factors influence health and illness. Then second question, the biopsychosocial model of health emphasizes in which of the following? The correct answer is the interplay of biological, psychological, and social factors of health and illness. Stress is defined as the physiological and psychological response to perceived threats or challenges. Question number 4, which of the following is an example of chronic illness influenced significantly by behavioral factors? The correct answer is type 2 diabetes. Then we have asked, which psychological construct refers to an individual's belief system in their ability to execute behaviors? The correct answer is self-efficiency. Which statement best describes the relationship between mental health and physical health? The correct answer is mental and physical health are interconnected. Each can affect the other. Health behavior, question number 7, health behavior change interventions typically focuses on which of the following? The correct answer is option B, motivating individuals to adopt healthier habits. Then we have question 8, which of the following is an example of health behavior change technique? So the answer is question number 8. The answer is option B, counseling patients on smoking cessation strategies. Then we have which of the following is best describes the concept of health promotion. So question number 9. The option educating individuals and communicating communities to adopt healthy behaviors. Option 2 is the correct answer. Then question 10. What role do social determinants of health play in health psychology? The right answer is option C. They influence health through social, economic, and environmental factors. So with that, we are done with day 11's assignment. Over to you, Roshni.
Right. Day 12, there was no assignment. So we come to day 13. That was your sports psychology. So quickly, the first one where we're excelling under pressure in the field of sports is called clutching. So for example, when there's a basketball player who wants to take the last shot only in the final seconds of the game, that would be an example of clutching. Second, the athlete assessment tool designed by the IOC, the International Olympic Commission, would be Sport Mental Health Assessment Tool 1, SMHAT 1. Then, which of the following is an example of an intrinsic motivation in sports? Out of the 4 options, obviously it's the one where you're actually enjoying the activity in itself and not relying on any other external source of motivation. What does the term social facilitation refer to in psychology? Similar to what it refers to in social psychology as well, which is based on Norman Triplett's experiment, where improved performance is seen in the presence of others. Question 5. Which of the following strategies does not help reduce social loafing? In a team sport, wearing the same uniform wouldn't really matter. In fact, it might just allow you to have more social loafing because everyone would be looking the same. Question 6. Which of the following is an effective goal setting strategy? So very easy targets or just doing your best goals just may not be enough. Setting process-oriented goals would be the most effective. Question 7. Which of the following is not a common psychological response to injury? Typically, motivation doesn't increase after an athlete goes through an injury. So that's not a common psychological response. Question 8. Which theory of psychology is the technique of biofeedback based on? It's based on operant conditioning. To be precise, it's based on positive reinforcement, where the reinforcement is by the signal displays, which prompts the patient to monitor and then change their own physiological response. Which of the following is not a sports psychology technique? Rationalization, because that's a defense mechanism, not a sports psychology technique. And the last one, a consistent sequence of covert and overt behaviors carried out by an athlete before executing a skill is the pre-performance routine. So that's for day 13.
Okay, let's quickly go through day 14's assignment. Okay.
I think that's the last assignment, right?
Yes, this is
We
the
don't
last
have
one.
Last assignment, yeah.
Yes. So, day 14, the first question, a crisis worker is assisting a client who is experiencing a psychotic episode. Which action would be appropriate out of all the options given? Option C, using empathetic listening to validate the client's feelings would be the proper response at the crisis moment. A client in crisis is threatening to self-harm. Which response would be the most effective? So the correct answer is option C, listen actively and empathetically while assessing the risks. Then question number 3, which is the primary goal of crisis intervention? out of all the ones given, long-term therapy or crisis intervention, hospitalization, the correct answer to provide medication, the correct answer is to resolve the crisis situation. So that's why it is known as crisis intervention. Which of the following is the key principle to crisis intervention? The correct option is empathetic understanding. So establishing power dynamics, maintaining distance, focusing on the past, all of these are not the correct responses. So what is the most effective way to establish rapport with an individual in crisis? The correct option is again by active listening, not by sharing or interrupting them, because that can just disrupt the whole process. So the correct response would be active listening. Which crisis intervention model focuses on problem solving and coping skills? The correct response is problem focused approach, option number C. What should a crisis worker do if an individual is suicidal? And the correct response is option B, call emergency services. We do not wait to fix the problem. We do not ignore the threat. We do not try to talk them out. We maybe try to talk to them, but the first we do is call the emergency services. What is the purpose of crisis assessment? The correct answer is option C, to identify the crisis situation and develop a plan. Question number 9, which of the following is the key aspect of crisis intervention with children? The correct option is option C, establishing trust and using play therapy. So question number 10, what should a crisis worker consider while working with an individual from a different cultural background? Whether they should use their own cultural belief, they should ignore the cultural differences. The correct option is being sensitive to the cultural differences and adapting accordingly. Then what is the goal of crisis intervention in the aftermath of a traumatic event? Do we re-traumatize the individual? Do we help the individual to process and integrate the experience? Do we ignore the event and focus on the daily task? Do we provide a diagnosis? The correct answer is option B, to help the individual process and integrate the experience. Which of the following is the key component of crisis intervention training? The correct response is practicing crisis intervention scenarios so that we can give proper intervention when necessary. Okay. Yes, so that brings us to the end of discussing all the assignments. And yes, so thank you so much. This is the end of the whole 15-day marathon that we had, right? And so thank you so much, everyone, for joining. Roshni,
Yes, I think it's been longer than required. So I hope you all are able to recall the answers that you put in. I hope you're able to go back. For those of you who requested for the recordings, again repeating, the recordings will stay live till Friday 5 p.m. You have till today 7 p.m. to answer and submit the assignment questions. I would suggest, since the recordings are there, you answer them on your own and then come back and listen to the answers just for a discussion. They'll be fresh in your mind. 80% of attendance and 80% of assignments is required to get your certificate. The certificate will take a little bit of a while, maybe a month or so, and it will be received in your registered mail ID. The internship we will conduct internships again and again, and we usually try and change things around. Some things stay the same, some things change each year, so that will continue to happen. Like Dr. Parekh said, most likely see you now next year in 2025, maybe with something new, maybe with a lot more innovation, a lot more to learn and then to discuss and imbibe as well. 80% completion of assignments, not marks. Otherwise, we would not be discussing the answers and then waiting for you to submit them. So it's not about the marks, it's about the learning. Have fun, enjoy, and thank you so much for being with us, part of this 15-day 75 hours of internship. Thank you, Anuna, and bye.
Thank
everyone.
you. Okay, bye-bye.